Okay. Good evening, ladies and gentlemen. Welcome to the mega event of Cochin Ophthalmic Club of 2021, which is Ophthalmology Reboot version 2, named as Worldwide Ophthalmology Revisions. We are basically going through 7 specialties in ophthalmology, covering all the specialties with some of the top speakers from across the globe. And we are officially going to start the sessions, the first session today being cataract. And for this, for inaugurating this worldwide ophthalmology revision, it is my pleasure to invite the president of the Kerala Society of Ophthalmic Surgeons, Dr. Babu Krishnakumar. He will officially inaugurate the worldwide ophthalmology revision, which is Ophthalmology Reboot version 2. Babu sir, please.
Dear Dr. Sai Kumar, President COC, Dr. Gopal, Secretary COC, Arun, Dr. Mahesh, Secretary KSIS, Dr. Rajiv Sukumaran, Scientific Committee Chairman, respected seniors, dear friends, faculties and delegates. We are here to participate in this prestigious webinar of Cochin Ophthalmic Club. Encouraged by the stunning success of Ophthalmology Reboot in 2020, they have a reformatted version now as World Webinar of Ophthalmology Revision 2021. True to the title, we have 15 international and 75 national faculties to revise you and energize you with advances in ophthalmology for imminent 3 days. A webinar an ophthalmic club cannot dream of so far have been materialized by COC. KSIC is proud to be a part of this academic extravaganza. KSIC is requesting all its members to get registered for Drishti 2021 during November 26, 27, and 28, a virtual meet left to hold due to prevailing COVID restrictions. New website of KSIS, which is more user-friendly, will be active in short time. I am extending my sincere thanks on behalf of KSIS to Dr. Sai Kumar, President COC, Dr. Gopal, Secretary COC, and the entire team of COC for inviting me to this world-class CME. With these words, I am happy to inaugurate the World Webinar of Ophthalmology Revision 2021. Thank you.
Thank you so much, Babu sir, for your kind words. I now request the Secretary of Kerala Society of Ophthalmic Surgeons, Dr. Mahesh, to speak a few words about this webinar.
Thank you, Dr. Sai Kumar, President Dr. Babu Krishnakumar, my friends in Cochin Ophthalmic Club and KSOS, and viewers from across the world. This idea of worldwide webinar or ophthalmology reboot was materialized last year, and it is, as you all know, it is very difficult to cover the whole ophthalmology in 2 or 3 days. But this webinar has an advantage of listening to the best speakers across the world under one platform, covering most of the important topics in ophthalmology. So any postgraduate student or practitioner can refresh his memories and regarding all the topics of ophthalmology in 2 or 3 days. So this last year it was a tremendous success with more than 10,000 viewers. And this year also, we are Cochin Ophthalmic Club is back with the same thing in a little formatted version. I hope everyone will take home something from this 2-day program. There will be.
Mahesh, you are muted.
Thank you.
Thank you, Dr. Mahesh. I now request the Scientific Committee Chairman of KSOS, Dr. Rajiv Sukumaran, to speak a few words. He has helped us a lot in setting up the new website of the Cochin Ophthalmic Club, through which we are live streaming this particular program. Dr. Rajiv, please.
Thank you, Dr. Sai. Respected President KSOS Babu sir, Secretary Dr. Mahesh, and COC President Dr. Sai, and Dr. Gopal, Secretary of COC. I should say it is a magnificent job. It's almost like an annual conference of a state conference that you're doing a 3-day program. It is actually putting me a lot of pressure so that I should go above this standard for my annual conference this year. I don't know, it's going to be very, very difficult with so many speakers and galaxy of speakers like this. Nobody should say that Drishti is less than this. I should go beyond this. So you're troubling me a lot, you both together. And Gopal, I don't know where this energy is coming from. He's doing a wonderful job, and I don't know, I don't have words to praise him. So good he is doing it. All single-handedly he was doing everything. Of course, other people are helping him, but this is marvelous. I wish this program all the very best. And I'll keep up to this, at least to the standard for the Drishti. Thank you so much for inviting me.
Thank you so much, Rajiv. Now, just a few things that I would like to mention. Gopal is going to brief all of us about the entire program. He'll actually be making a slideshow. So before that, I would like to also mention the support and cooperation of the Milmet division of Sun Pharma, headed by Mr. Raju, who's here, who's the national manager. Raju has, of course, been a very close friend for a very, very long time. I think acquaintances with all of us with more than 20-25 years. So he has been very helpful in setting up this entire program and reaching the brochures and flyers about this program far and wide across the country, in every nook and corner of the country. So I think that is one thing that I would like to mention at the beginning of this. And now the stage is yours, Dr. Gopal. As Rajiv said, this is actually a brainchild of Gopal. What we did last year was also, and even picking up the persons who are going to be the chairpersons of each session, everything has been done by him. I have been happily, being there as president of the organization. The hard work is being done by Gopal. So a great team we are having in Cochin Ophthalmic Club. So Gopal will now brief us about the entire 7 sessions, and then we will go into the cataract session. Hopefully, Dr. Arup will be joining us by the time. We already have 2 international speakers who are already in. Welcome, Dr. Rashid from Bangladesh. Very nice having you. Welcome. Welcome, Dr. Lee from Malaysia. It is very nice having you. Minu Matan, our very good friend, is already there. Arun, our scientific committee chairman, is here. Welcome, Arun. And I also have to mention the efforts put in by Lisa, who's a postgraduate student at Amrita, for coordinating this entire cataract event. So over to you, Gopal, for your presentation.
Thank you very much for your kind words, Dr. Sai and Dr. Rajiv and Dr. Mahesh. It's indeed a real pleasure to have all of you and to actually run this conference, World Webinar of Ophthalmic Revisions. So basically, in this 3 days where we have given 3 hours to each subspecialty, there are 7 subspecialties which we have coined. So through this about 24-hour program, we aim to revise the whole 360-degree ophthalmology. So each session has been given to a particular person as chairperson, and they have basically done the program. So Dr. Arup and Dr. Sai were chairing this, and Dr. Soni was moderating this. So between the 3 of them, they have arranged the cataract program. So like that, each of these is like that. So coming to the program, this is the total ophthalmology revision. We have, it's a combined effort of Cochin Ophthalmic Club and Kerala Society of Ophthalmic Surgeons. As I said, Cataract chairperson is Arup Chakrabarti, and moderators Dr. Sai Kumar and Dr. Sony George. Glaucoma, Dr. Ronnie George is our chairperson, and co-chairman is Dr. Aditya Niyog, and moderators Dr. Manoj and Dr. Abhilash. That will be tomorrow morning. Uveitis, Dr. Jyotirmay Bishwas is the chairperson, and Dr. Risha and Dr. Natasha will be moderating. That will be tomorrow afternoon. And tomorrow evening, we have pediatric ophthalmology, none other than Dr. Pradeep Sharma, who is a chairperson, and co-chairperson is Dr. Rohit Saxena, moderated by Dr. Neena and Dr. Thomas Aru. Cornea and refractive surgeries on Sunday morning at 8:30. Dr. Namrata Sharma is the chair, and Dr. Anil and Dr. Vinay are the two moderators. And then again, retina by Sunday afternoon, Dr. Giridhar and Dr. Lalit Verma are the chair, and moderated by Dr. Thomas Chirian and Dr. Mahesh Gopalakrishnan. Oculoplasty and ocular oncology, Dr. Santosh Hanover is the chair, Dr. Annie, Dr. Marian, and Dr. Fairuz will be moderating. So this is, we have an array of, international speakers here. You can see that we have about 15 international speakers: Dr. Abhi Jacob, Dr. Arun Narayan Swami, Dr. Berit Tomato, Dr. Bernin Cheng, Dr. Carol Shields, Dr. David Chang, Dr. Deepta Gate, Dr. Gangadhar Sundar, Dr. Mayank Nanavati, Dr. Michael Kasim, Dr. Munwai Lee, Dr. Rashid Alam, Dr. Shishuko Ko, Dr. Soon Fek Chi, and Dr. Vishal Janji. So they, along with about 70 national faculty, like this is the cataract faculty, this is the glaucoma faculty that we have, this is the uveitis chaired by Dr. Jyotirmay Bishwas sir, pediatric and neuro-ophthalmology by Dr. Pradeep Sharma and Dr. Rohit Saxena, and these are the faculty: cornea, retina, oculoplasty. As you can see, we have the best of the best in the world, actually. We have close to about 95 faculty in all who will take us through this journey of 24 hours, the whole 360-degree revision of ophthalmology. So friends, we are in for a treat, and we have to start the cataract session in about the next 10 minutes. So over to you, Dr. Sai.
Thank you, Gopal. I also welcome Dr. Tushya Omprakash. Hello, Dr. Tushya. Welcome.
Hello, sir. Good evening. Thank you so much, sir.
Good evening.
Thank you, sir.
Dr. Deepak. Deepak is a very prolific cataract surgeon from Bidar. Good evening, Deepak.
Yeah, hi, sir. Hi.
Dr. Sai,
hi.
may I
Welcome.
also brief regarding the website that we have?
Yeah. You
So
can
that
just go. We have
you
a few minutes for that. And then before Arun will propose a vote of thanks for the function, and then we can get it on.
Yeah. So just to share this is our website which has been created now. So we have the scientific program here. So if you click on that, it will basically go into the PDF of the program. And one second.
Is it a bit slow? Yeah.
No, it's actually, so that's a scientific program. We have a doctor's launch wherein it can take us to another Zoom meeting. I'm not opening that Zoom meeting because it will close down this meeting. So that's there. Again, if you can see, this is the conference hall. If you enter the conference hall, you can actually go to the meeting. And we have the Sun Pharma trade stall also. The doctor's launch actually takes us to a doctor's meeting. So this is a website that has been very interactive, which will help us almost look like a conference. So this is something that we don't have nowadays. So that is the conference website that we have created. Now over to Dr. Thomas Arun.
Good evening, everyone. Respected KSOS President Dr. Babu Krishnawar, sir, President COC Dr. Sai Kumar, Scientific Committee Chairman KSOS Dr. Rajiv Submaran, Scientific Committee Secretary of COC Dr. Gopal Pillai, Scientific Committee Chairman of KSOS Dr. Mahesh, respected faculty and my dear friends. Dr. Sai Kumar and Dr. Gopal have arranged a real feast, and I think it will be a memorable event for all postgraduates and trainees, and something that they can always go back and always refresh when they're preparing for the exams. Without taking up any more time, I welcome all all those attending this webinar, and I hope that all the trainees especially will gain a lot and something that will help them in their exam preparation for the exams. Thank you.
Thank you, Dr. Arun. And I think we can introduce the first speaker.
Dr. Sai, I think you can go through the whole presentation of speakers now, because we have 5 minutes more.
Yeah.
And then introduce them as and when they come.
Can you share the screen, Lisa? The meeting is chaired by Dr. Arup Chakrabarti, who is a very passionate teacher, a very prolific cataract surgeon from Kerala. He has edited 3 books. He has presented in most of the international meetings year after year. His instruction courses in international meetings are a big hit. I have attended quite a few of the meetings with him. And he's a reviewer of many prestigious journals. He has also held a lot of posts in the All India Ophthalmological Society as well as the Kerala Society. He is in fact the incoming president, the president-elect of the Kerala Society. He's also the editor proceedings of the All India Ophthalmological Society. So we are really happy that Dr. Arup has agreed to take the lead in this cataract session and also help us get some of the best speakers across the globe for this session. Can I have the next slide? Yeah, Dr. Soni George, who will be moderating this session along with me, is the head of the department and senior consultant of ophthalmology at Medical Trust Hospital. He is again a very innovative cataract surgeon. Almost all the new multifocals, trifocals, everything that is launched is usually tried out by him. He's an excellent cataract surgeon, a left-handed cataract surgeon, whose videos are a treat to watch. So Soni will be moderating the session along with us. Of course, I'll be there. I am the president of the Cochin Ophthalmic Club, and I'm also the
Dr. Soni can introduce Dr. Sai.
Yeah. I mean, that nothing to. We'll just move on.
It will be my pleasure to introduce Dr. S. J. Sai Kumar, one of the tall pillars of the Cochin Ophthalmic Club and KSOS. He's a product of a government medical college, Trivandrum, and he's done his fellowship in anterior segment from Coimbatore. He's got more than 20 years of experience in specialties, cataract and glaucoma. And he's a constant presence in national and international conferences and has conducted many instruction courses in the national and state level. And he is the president of the Cochin Ophthalmic Club, and he's held many posts, including editor journal, chairman scientific committee at the state level, and he's given a lead for many research projects in ophthalmology. Presently, he is the medical superintendent and head of the department of cataract and glaucoma at the Giridhar Eye Institute. And welcome, Dr. Sai Kumar, to be the moderator of this session.
It's my, has Arup joined?
No, he hasn't joined.
I don't think so.
No, I think we can start, sir.
Yeah. So it's my pleasure and privilege to introduce Dr. Mohammad Rashid Alam from Bangladesh. Dr. Alam is a cornea specialist and a cataract surgeon. He did a short-term ICO fellowship in cataract surgery from Mahatma Eye Hospital in Nagpur in 2013 and a long-term fellowship in Cornea in the Ibsahani Islamia Institute in Bangladesh in 2015. He's currently the assistant professor and consultant of cornea at the same institute and also the deputy director of the Ibsahani Eye Bank. So his areas of interest are anterior lamellar keratoplasty, endothelial keratoplasty, and eye banking. And it's indeed a great pleasure having you with us, Dr. Rashid Alam. Dr. Rashid will be speaking to us on a topic which is of interest always to everyone. You know, phaco in soft cataracts. When we always think of cataracts and go to conferences, everyone shows you all the hard cataracts, the rock hard cataracts, the small pupils and things like that. But no one speaks about a sticky situation which we always encounter, which is the soft cataract. And Dr. Rashid, welcome to our international webinar. And you are inaugurating this session. You are the first speaker in this entire webinar. So welcome. Please go ahead with your talk.
Should I share my screen?
Yes,
yeah, I would take an opportunity to welcome Dr. Arup Chakrabarti, who has joined us.
Arup boss has, yeah.
So, sir can speak a few words before we start.
Good evening, friends. I would like to congratulate Cochin Ophthalmic Club, Gopal and Sai for organizing a fantastic program. So much of effort has gone into this program. And I think we will just start off because it is already 8 o'clock, 6 p.m. And we have to, a lot of good talks coming up, good, lovely speakers going to speak to us. Thank you very much for joining in.
Thank you very much, sir. Thank you very much for chairing the session.
You can share your screen, Dr. Alam.
Okay. Okay, my screen is visible, right?
Yes, you're visible.
And
yes,
I'm audible.
Yes, sir. Yes,
yeah.
Please go ahead. Yeah.
Okay, sir. So thank you very much. Thank you very much for the kind invitation. And I would like to give special thanks to Arup sir and the Cochin Ophthalmic Club and the Kerala Society of Ophthalmic Society for giving me the opportunity. Today, I want to talk about the phaco in soft cataract. So I'm Dr. Rashid from Bangladesh. So I have no financial disclosure to disclose. So with the cataract surgery slowly and but surely moving into the realm of refractive surgery, more and more patients are presenting earlier for the cataract, and these are all soft cataract. And soft nucleus can be a vexing situation for the cataract surgeon who's accustomed with the fracture and nucleus and doing cataract quadrant before emulsification. So I like to share a video. In my early days, I was in trouble. So this is a soft cataract, and I was very casual doing a very small rexis and not casually doing all the hydro procedure. And the rotation was not what isn't great. So what I wanted to do, I wanted to trace the cataract and nucleus and divide it into two halves. But as you know, like soft cataract, always there is cheese wearing. You cannot chop, you cannot crack. And using vacuum holding the nucleus, always the nuclear material comes into the phaco tip, and there is loss of like holding. No holding is there. So I was very worried. What shall I do? And so I wanted to do flip. So I wanted to take out some portion. So I will make some space. Yes, there is the portion. And it will create some space so I can rotate the nucleus freely, more freely. And I'm waiting to have, a suitable place to hold on. But it's not there still. You need to have patience. And there it's hold on, and the nucleus is slipped, and I have made it possible, without any complication. So this soft cataract, like trying to embed and exert tightly wedge the quadrants can result in repeated loss of suction and ultimately creating a ball. And when the ball is formed, you want to take it out, it becomes more problem. As the rhexis was very small, after giving the IOL, I just enlarged the rhexis up to optimal size. So the challenges, so it may be challenge to rotate the nucleus, since a dialing instrument tends to pass through the soft nucleus and it doesn't rotate. For the same reason, it's very difficult to do, that is chopping and cracking. The lens meter tends to strictly adhere to the capsule, so it's very difficult to separate. Soft nucleus, lack of rigid cleavage plane. There is a cleavage plane is very, it's not rigid, so you cannot do the cracking and, you cannot do the cracking and that is chop. Using a vacuum to impale the nucleus, the lens meter comes out and forming a ball formation. Further you go, you make a plate, and it's very difficult to, remove the plate from that small opening of the enterocapsule. And always there is a risk of phaco-tip going through rapidly to the soft nucleus and resulting in posterocapsular rupture. So in my opinion, the keys are good hydrodissection and delineation, avoid small rhexis, and good nuclear rotation is mandatory. So what I do in my rhexis, as you can see, I do the rhexis around 5.5 to 5.75 millimeter of diameter, and so that you can when you need, you can just do the hydroprolapse and you can emulsify the that is nucleus. The ideal aim of the rhexis is just to overlap the intraocular lens optic all around. So this is my optimum size of the rhexis. Next comes the hydrodissection and delineation. I do a lot of hydrodissection and delineation. Usually, like I want to do a multiple hydrodelineation so that the center part is very weakened, and you can just you can just suck out the central soft nucleus. So you can see I'm doing hydrodissection. You can see the fluid wave going, then hydrodelineation one time. You can see the ring, you can see another ring. So multiple hydrodelineation in different level of the nucleus. So you can see 3 or 4 that is good, the golden ring. The care should be taken not to inject too much and too fast fluid, so that the nucleus doesn't, there is no capsular block to, go out the posterior capsule. Now the nucleus management. There are many techniques, many methods you can do, but in soft cataract, there is no one size fits all. So you need to know the 2 or 3 different techniques, because which one you fit, you doesn't know. And if it fits, it doesn't fit, you can switch it to another one when that technique doesn't do well. So what I do phaco flip, lollipop, free pen chip, and stop and chop, divide, conquer, and you can do the phaco prolapse and supracapsular phaco emulsification. So this is phaco flip. I do a central trench, very thin and deep, so that I can divide the nucleus into 2 halves. As you can see, I'm dividing it into 2 parts. Then with the, like phaco probe, with the only aspiration, I want to, do a hemi flip of the half quadrant. And again, the other quadrant, I do another hemi flip. So this is one of the phaco flip I do a lot. And if the nucleus is very soft, you can do a single flip, as you do a capsular rhexis a little bit larger, do the hydrodissection and delineation, and wait until you create a vacuum. So you will stay in the full position 2. And once you create a vacuum, the nucleus will flip. So you can see the flipping of the nucleus. And later on, you can eat in one piece, and the cortical clear, that is epinuclear clearance, you can do it. So sometimes things doesn't go in your way. You know, I wanted to do a hemi flip, so I wanted to crack the nucleus, but what I'm doing, you know, like dividing into two half with so much force. So I said, no, you won't do it in that way. So I just waited to get a very good grip with the phaco probe so that I can single flip the nucleus. So you can see I'm waiting to get my grip. And once I get the grip, you can just flip the nucleus into, you know, like pop it out from the bag, and you can just emulsify the nucleus. So lollipop is another new technique, and with that technique, you have to be, you know, do a multiple hydrodelination and wait for central part to pop out. So you do the aspiration, and just you can see the that is the central portion pop out, and you just emulsify the nucleus, and the rest is not a problem. So in another case, I wanted to do a lollipop. You can see the multiple hydrodelination is there. And I just did, you know, emulsify the central core, and it became like a bowl. So then I waited for the, you know, like the rest of the nucleus to come out. So it will be like some kind of tip and flip method. So you can wait for it. And once, yes, so the nucleus is emulsified. You can go for the stop and chop, and you know, it's most, I think this is, everybody does it. So the nucleus is a little bit not that soft, so you can do a trench, narrow and deep, and you can do your modified stop and chop technique. You divide with the horizontal chopping and divide the nucleus in 2 half, 3 half, 4 half, 5 half, and you can emulsify 1 by 1 quadrant when the piece, you know, that is separated. So stop and chop, you can do it with the horizontal chopping. Another thing, back to the basic, you can do the dividing. This video I have borrowed from my friend Ashraf from Bangladesh. So you do a very thin and deep trench, so that the, you know, like yes, you can see a very deep trench, and just crack the nucleus into 4 quadrant. So divide and conquer, I know everybody has know this method. You can do it very safely. So this is another case of hydroprolapse. Sometimes the nucleus is so soft, and if you want to, you know, do a chop thing, the nucleus, whole nucleus pops out into the anterior chamber. So sometimes it occurs, you can do it by that way, but I don't want to do in a, you know, like I want to do the endocapsular phaco. So in that case, you need a very small power, and somebody, you know, someone like, you know, with a high vacuum, high flow rate, so that it comes very quickly. So one is the next step is the cortical clearance. It's as usual, you do cortical clearance. You can see the cortical removal, tangential, so you don't give a stress on the zonule. For the young patient, you put some, you know, like you give some extra time to remove all the cortical matters from the periphery, and I always use the bimanual you know, because I can approach 360 degree, but if you're confident and, you know, comfortable with the coaxial, with the bend tip, you can do it. Capsular polishing is very essential, you know, like early PCO is very frequent in case of young patient, and they are very aggressive. And so you can see, you polish the capsule posterior and anterior subcapsular very meticulously, so that, you know, like we can prevent the PCO especially in the young patient. So this is another video. You can see I'm doing the intracapsular polishing. So IOL implantation is as usual. I just wanted to show you can do it. I usually do with the BSS solution with the bimetal irrigating probe. So I'm very comfortable with that. Sorry. But you can always do with the visco and implant the that is IOL into the capsular bag. So in my conclusion, I want to say that understand the surgical challenges. What are the challenges you have? Then the machine parameter setting. I usually do in case of very soft cataract, my power is like around 20%, and aspiration flow rate is like 22 to 25, and the vacuum is like highest, it's like 200 to 250. So machine parameters is important. Avoid small rexes, good hydroresection, delineation, and nuclear rotation. Apply one of the best method you fits, we are confident with, and like you to switch to another one when it doesn't work, and keep patience. So these are my references. I like to thank again. Thank you very much for the kind invitation and patient hearing. Thank you, sir.
Thank you, Dr. Rashid Alam, for that comprehensive and exhaustive talk on dealing with soft cataracts. Your highlight was the wonderful videos which you had shown in about each technique. Like you said, there is no single one technique which can be used for all soft cataracts. You may have to have a plan A, plan B, plan C. When you plan for one technique like a chip and flip, it may not work. You may have to go for a hydroprolapse and vice versa. One question I would like to ask you is, in all your cases, you have shown very, very well dilated pupil. In most of the cases, when you're dealing with this soft cataracts and you need a little more time, the pupil shrinks. So what is your strategy in dealing with meiosis intraoperatively, especially in soft cataracts?
So for perioperative meiosis, it's very difficult, like for the soft cataract, and if the pupil is small, you struggle a lot. So for that reason, you can use the intracameral adrenaline, and sometimes with the dispersive type of viscoelastic, that is OVD, you can make it somewhat, little bit bigger, so then you can approach. And if it doesn't happen, I always go for the iris hook. That is my, rescue instrument. So I use the iris hook. So once the pupil is dilated, whatever the cataract is, you can do it.
Dr. Rashid, the very nice videos, and you have shown almost all the techniques. There are a few points I would like to make. Where I differ from your technique is, number one, I don't perform a hydrodelineation because that leaves you with an epinucleus. And as Dr. Soni just mentioned, when the pupil comes down, removal of that epinucleus becomes very, very tricky. So that is number one. Another technique that I employ is, you'll have some of the soft cataracts which are neither here nor there kind of cataracts. You can't chop them, you can't crack them. In those situations, after we have debulked the significant portion of the soft cataract, we can use a visco displacement, inject an OVD at the capsular fornix, so which pushes out the residual lens matter into a more accessible area within the rexis margin, and then it can be aspirated. And another word of caution is when we are employing the the anterior chamber phaco, the phaco flip, and so it is important to use a good quality OVD to protect the corneal endothelium, because there's a lot of irrigation that is happening. It's not the phaco power only, it is a lot of irrigation that is happening, and
the turbulence,
and all that. Otherwise, I think your points. And I would also like to classify soft cataract into two types. Those with a posterior polar component and those without a posterior polar component. And I have a different strategy for each category. Any other questions?
Sir, I just left the posterior polar thing because it's entirely different. The approach is different.
It is just for the sake of discussion, I brought that point out.
Yes.
I got a message from Lisa that we have to. We have You have already confined to your time limits, but we have to respect time. And we have a lot of talks coming up and a lot of good discussions to be followed. We'll follow these talks. So Dr. Lisa will be maintaining the time, the clock here. And I think we need to finish all our talks in time so that every speaker gets his share of the time allotted. We have some more, another minute, 2 minutes for this discussion. Sai, this is keynote is 15 plus 5? Or?
Yeah, 15 plus 5. Yeah. So this is total is up to 620. We are 618 now. Yeah. Just as a rejoinder to what Dr. Arup just said, sometimes you find that the softer cataracts have more DM folds the next day compared to the hard ones. The hard ones, you are very careful inside the bag and chop them and, eat them inside the bag. The soft ones, you try to, flip it up and, come very close to the endothelium.
Yes.
So I think a dispersive viscoelastic definitely goes a long way.
And this is very unpredictable kind of a cataract. And like one of my friends said, at the end of it, it is phaco somehow.
Yeah. This is all the Dr. Rashid shows excellent cases, but all the cases hidden in the Centurion system. This is the most advanced phaco system which is available in the market. Okay. And most of the cases, some cases is a balanced tip and some cases is a mini flare tip with the AVS system. So this is a technique which, this tip you can do a very good lollipop technique, flip and chip, this you can do. But if you do a phaco in the basic machine, in a say Apashami machine and basic machine in a softer cataract, you cannot use this all as technique for this cataract. But you have to stick to the basics, either a 2-quadrant, or you have to do some visco displacement of the softer nucleus, or hydrodelineation, pop up the nucleus and do with the good viscoelastic cover, you have to do the anterior phaco. But it is all this technique because he's using this as so absolutely high-end machine and which has a absolute balanced control of anterior chamber fluidics.
Yes,
so this technique looks very simple in this machine, but it may not be so simple in very basic machine. So you have to be very careful. Thank you again.
Even said the Laureate doesn't work in that way also.
Yeah, you have to, yes, that's a technique of, depends on which machine you are using, which type of cataract and which type of tip you are using, phaco tip. This is a good technique. All this technique is a very good in Centurion system with the balanced or mini flare AVS system tip, but it will not work in a easy tip, in Ortelli or normal pen tip or the stellar is coming. So you have to be different in your own approach here. Yeah.
Thank you so much, Dr. Arup Bhowmik, and welcome again. Hi.
Hi.
So we'll move on to the next. Lisa, can you share the CV of Dr. Deepak? Sony, can you please introduce Dr. Deepak?
It's my privilege to introduce Dr. Deepak Megur. I think most of the audience will be familiar with this name because most of us have seen teaching videos by Dr. Deepak Megur. He heads the cataract and glaucoma departments at the Megur Eye Care Center, Bidar, Karnataka. And he specializes in complex cataract surgeries and is committed to teaching surgical skills through his website and his YouTube channel. He's won a lot of awards and recognitions, including the overall Best Video AIS 2020, Best Paper of the Session in Cataract AIS 2018, Best Free Paper Cataract and Best Video KOSC, Best Paper APARS 2014, MM Joshi Overall Best Paper 2009, and the Best Video Glaucoma Society 2010. He's got more than 200 presentations in national and international meetings. And he's a reviewer of the IJO. And today he'll be speaking to us about phaco in incomplete rexes. As we all know, it's a big challenge in inexperienced hands or in beginners. And but in an experienced hand, definitely it can be done. So he will take us through how to manage phaco in incomplete rexes and what are the red flags and how to take care of that. Over to you, Dr. Deepak.
I want to share my screen. Yeah.
Please.
At the outset, I'd like to thank Dr. Arup sir and Cochin Ophthalmic Club for the opportunity, and congratulations to the entire team for hosting this wonderful meet here. So my video has the audio also. Please let me know whether the audio is audible. Just let me know once it starts. So my topic is going to be on how to phaco when we have an incomplete rhexis. I usually...
This 65-year-old man with an intermittent cataract,
Very clear, very clear.
and the rhexis has run off to the equator. This video is not about the reasons for the Argentine flag sign, rather than what to do once we have it. Should I phaco or should I convert? Now let me get this point very clear now. There is no harm or shame in converting to manual SICS or ECCE in such a situation. The decision to continue with phaco or to convert should be based on these following factors: skill level and experience of the surgeon, density of the nucleus, how good is the visibility, the amount of pupillary dilatation and the corneal clarity. And lastly, presence of coexisting pathologies like the status of the corneal endothelial health, pseudoexfoliation, etc. Coming to this case, the nucleus is not soft, but it's about grade 3 and does not appear to be very hard. I think it's manageable. The pupil is extremely well dilated and the cornea is quite clear, so visibility is not an issue. Well, I have been in this situation many times in the past, and I am backing myself to meet the challenge in the event of any intraoperative difficulty. Well, I have decided to continue with phacoemulsification in this case. And let's see how things go. Before I start, let's understand with this present situation what can go wrong in the worst case scenario. The extended anterocapsular tear can extend posteriorly beyond the equator and can cause PC tear, which if undetected can result in nucleus drop. The goal is to prevent the tear from extending onto the posterior capsule. And the golden principles to achieve this goal are: number 1, maintain chamber equilibrium at every step of the surgery, minimize stress on the torn edges of the anterocapsule, and abort phaco if situation worsens. Let's get in live. The first thing I need to do is to enlarge the capsular opening. But before I do that, I need to decompress the bag. Carefully and slowly, the swollen cortex is gently aspirated from underneath the anterocapsular flaps. Before switching hands, OVD is injected to prevent shallowing of the antechamber. The OVD is injected above the anterocapsule. If we inject here, that is in the opening below the anterocapsule, the chances are the tear can extend posterior to the equator. Using a micro scissors, a tangential cut is given to the anterocapsule, and I'm using a forceps to trim the capsule. The same procedure is repeated on the other side. I didn't want to make a very big opening, but this is slightly smaller than what I would have liked. I have chosen to perform stop and chop technique for nucleus management in this case. While sculpting, I'm very careful that I don't exert any stress on the bag. I'm using good amount of phaco energy to ensure that I don't push at the nucleus. I'm also aware that I cannot rotate the nucleus before creating some space. I thought the trench was deep enough, and I'm trying to do lateral separation carefully. The posterior plate in the inferior half is separated, but the subincisional half of the posterior plate is not separated. I am skeptical to use any more force. I thought I will chop and take out one piece, which would create more space in the bag and then would be less stressful in the bag during further nucleus manipulation. And then go and emulsify the two free pieces. Each of these pieces are pulled out of the bag and emulsified in the supracapsular region. The chamber is refilled with OVD. Since the bag is empty, the nucleus rotation is less stressful to the bag now. The heminucleus is then chopped into two fragments. Then one of the fragment is pulled out of the bag. Now in this situation, I need to be extremely careful not to have lens chatter because the endothelium is quite close here. So reducing the amount of lens chatter is going to be invaluable in minimizing the endothelial trauma. The remaining fragment is emulsified in a controlled manner. There is no cortex to aspirate. The bag is formed with OVD and the lens is implanted. So now we have a situation where the rhexis is not continuous, and so how do we go about now? The first thing I do is to enlarge rhexis by snipping at the margin in the other quadrant in the form of a tangential cut, so that I can enlarge the rhexis using a microforceps. In this case, I have decided to go ahead with the phaco emulsification. The pupil is well dilated. The nucleus is not soft though, but the good thing is that the edge of the tone anterior capsule is very well visualized and is currently everted and fluttering, which is a good sign. The principle of no hydrodissection and minimal rotation of the nucleus will be followed. With one eye on the flap, I begin phacoemulsification of the nucleus. Before performing the first vertical chop, I am creating a small trench by sculpting the central part of the nucleus. The idea is to get a good purchase of the central core of the nucleus. The first chop is done, and as I am laterally separating the fragments, I am conscious to be very gentle with my lateral separation maneuvers. The idea is to prevent any stress on the tone edge of the anticapsule. The second chop is done now, and I have a free fragment which I pulled out of the bag, and then I'm emulsifying it. The emulsification of the quadrant is being done in the antechamber and completed. Now the nucleus is rotated gently and the subsequent vertical chops are done to divide the heminucleus into two more smaller fragments. These two fragments are being emulsified in a controlled manner. As can be clearly seen here, the plane of emulsification is much more anterior than what I would have liked, but the circumstances are such that emulsifying it in a much more anterior plane is a safer option. Before coming out, I inject OVD through the side port to prevent any shallowing of the antechamber. Now we want to maintain the anterior chamber equilibrium at every step of the surgery. That's very critical in such situations. The second heminucleus is then divided into smaller fragments, and then each of them is emulsified in a controlled manner. OVD is again injected through the side port before coming out. There is very little cortex which is then aspirated out. The OVD both in front and behind the lens is irrigated out. It's ensured that the haptics are away from the area of the tone rhexis before closing. That's it, the case is done. This is a picture on the first post-op day. So to summarize, a discontinuous rhexis creates a weak area in the anterocapsular opening, and it carries the risk of a wraparound tear extending to the posterior capsule during nucleus manipulation, and carries a high risk of nucleus dropping into the vitreous. Now if I decide to continue with phaco, here are the 7 principles I would like to follow. The first thing I would like to do always is to enlarge the other quadrant of the rhexis, especially if the capsular opening is very small to begin with. By enlarging the capsular opening, it will ensure lesser stress on the bag during nucleus manipulation, especially during division of the nucleus. Typically, I avoid hydrodissection and minimize nucleus rotation in eyes which have a discontinuous rhexis. The third most important principle is to ensure that the chamber equilibrium is maintained at every moment of the surgery. This is probably one of the most critical aspects, because sudden shallowing or sudden deepening of the chamber is going to extend the torn edge of the anterocapsule beyond the equator and into the posterior capsule. While performing phacoemulsification, I ensure that I keep a close watch on the tone flap at every moment of the surgery. If the flap is mobile, fluttering and everted, then it's all good. This is the flap motility sign. However, if the flap is stiff, inverted, and not moving at all, then it is not a good sign. It's indicative of the tear having extended beyond the equator into the posterior capsule. During nucleus chopping maneuvers, lateral separation has to be very gentle to minimize any stress on the torn edge of the anticapsule. After the first chop is done and the first fragment is created, invariably I pull it out of the bag and emulsify it first. This helps in creating space within the bag, which ensures that there is lesser stress on the weak capsular margin. And finally, the fragment emulsification is done in the antechamber above the anticapsular plane. Hence, it becomes mandatory for us to protect the endothelium by using adequate amount of good dispersive OVD. So these are the 7 principles which I try to follow when I'm performing phacoemulsification in an eye with an incomplete rhexis.
That's it, sir. Thank you for the opportunity, and over to you, discussion.
That's a real master class, Dr. Deepak. And one thing that I really notice and want all the the juniors and everyone watching this to follow is the very well stained anterior capsule, the uniform, beautiful staining of the capsule, which gives you so much visibility of the capsule. If you have small areas of patchy, areas where you can't see the capsule well, you are extending the rhexis on the other side, everything becomes more trickier. So I think beautiful video, Dr. Arup.
Yeah, Deepak, as usual, lovely video demonstration. The most important aspect of this managing this complication is the decision making. Whether you convert to a safer technique or continue with phaco. See, if you see carefully, Deepak had shown cases where the nucleus is pretty brittle. Now, if I have a case where the rhexis tear has run off to the nasal side, and it is a very hard cataract with a posterior leathery plate, and the cornea is not very good, AC is shallow. Plus, the bystanders, the patient or the patients are not very, understanding kind of personalities. I would not do a phaco, I'd convert it to a non-phaco technique. And whatever technique Deepak had mentioned, I think in the same technique will give you good result in brittle cases. Maintain the anterior chamber depth all the time. Lateral separation should never be performed very vigorously, and it is just angular separation at the depth of the nucleus. No, don't think, because you do not want the nucleus to be stretching out the capsular rhexis, which is already torn, and you don't want to stress out the back. So just go at the bottom where the crack line or the chop line is developing, and perform multiple manipulations, and come proximally, bring it towards the center. Work always at the mid level of the back, never work close to the posterior capsule. I think these are the tips which I would like to give, and Deepak had done a wonderful job, lovely videos and very good, very well enunciated points.
Can we move on to the next talk? Dr. Lisa, can you show the slide introducing Dr. Tushya? Dr. Tushya Om Prakash is the director in the Dr. Om Prakash Eye Institute in Amritsar. He's a consultant in cataract and refractive services. He's a faculty to various national and international conferences. He has co-authored chapters and books on phacoemulsification. He has also won the prestigious Best Paper Award at the ASCRS in 2018, and also awards in Kyoto, Japan. So he's a young star, upcoming star in the phaco horizon in the country. Over to you, Dr. Tushya. We are ready to hear you.
Thank you so much for the introduction, sir. First of all, I would like to thank Dr. Arup sir and Cochin Ophthalmic Club for giving me this opportunity. Is it?
No, yeah, now we can see.
Okay. So today I'll be talking on conquering the Morgagnon cataract challenges. As we all know, there are structural specificities and challenges in Morgagnon cataracts, like they have fibrous, rigid, or calcified anterior capsule. There is liquefied lens cortex. There is lack of epinuclear and cortical support. Then there is associated zonular weakness. And often the nucleus, which is hard, is sunken and variably sized and freely floating. And then there is often associated vitreous syneresis. So these are the two graphical pictures where you can see that in this Morgagnon cataract, the nucleus is freely floating in nature with no compartments, unlike in intumescent cataract, where you can see that there is an anterior compartment and a posterior compartment, and there's an increased intralentricular pressure, especially from the posterior compartment, which often leads to anterior capsular tears while performing capsular excess. So there are challenges associated in the biometry also. There's always a challenge to have an accurate IOL calculation, even with IOL master lens star, due to the presence of opaque cataract due to lack of fixation. So we often use the contact method of immersion technique. B-scan should also be done to rule out any retinal detachment. And of course, ACD and lens thickness should be always noted prior to the surgery, which gives us an idea if it is a swollen lens or absorbed lens. Other risks involved in Morgagnon cataract surgery are like there's a high risk of zonular dehiscence during the surgery, a risk of posterior capsule rupture, bag emulsification, risk of anterior capsular tear, endothelial cell damage, nucleus dislocation into the vitreous, and a poorer visual outcome. Coming to the capsular excess challenges. So there is always a difficulty in capsular excess. There's a difficulty in initiation of the rexus because of the anterior capsular structure. And then there's because of the partial empty bag, there's a difficulty initiation. And then often there's an association of a weak zonulopathy, which often there's a difficulty in initiation. Then there's a decreased visibility of anterior capsule, especially when there's after initiation, you can see a crest of cortical fluid coming, and then there's a decreased visibility of anterior capsule. Then always there's a challenge of completion of rexus, there's a fear of peripheral extension, and then if there's and while completing the rexus, if you have weak zonulopathy, then there can be damage to the zonules as well. Coming to the anterior capsular tear, the chances of anterior capsular tear, as I had mentioned before also, the chances of anterior capsular tear are less in a case of Morgagnon cataract, because the posterior compartment pressure or the intralentricular pressure, especially in a Morgagnon cataract, which is freely floating, is less as compared to the intumescent cataracts. But you can always have an anterior capsular tear if there is an association of weak zonules. So I would like to tell you that Dr. Deepak had explained beautifully how to manage an anterior capsular tear, and he also showed the significance of flap motility sign, and he showed such good safe phacoemulsification techniques whenever you have an anterior capsular tear. Just to add on whatever he showed, I'm just going to show you a graphical animation of the flap motility sign, and which tells us whether to continue phacoemulsification or tells us when to stop phacoemulsification. It helps us to identify whether the tear is pre-equatorial or post-equatorial. So this is just a graphical animation.
These animations show that the pre-equatorial tear is everted and freely fluttering in nature. Hypothesis for fluttering flap is that the end point of the extension of the flap functions as the pivotal point for the flap. The flap, being short, is responsive to the fluid dynamics of the anterior chamber and thus flutters freely. But once the pre-equatorial flap extends beyond equator, the flap becomes inverted and stops fluttering. As there is a breach in the barrier in the event of posterior extension of the extended anterior capsular tear, there is pulling down of the anterior capsule tear. Pulling down is because of the combination of the higher pressure of anterior segment, increased capsular bag volume, and the negative pressure of the posterior segment that pulls down the bag complex and makes the flap lie flat and eventually become inverted and non-responsive to fluid.
So coming to the other challenges in nucleus management of Morgagnon cataract, cataract are. Due to the variably sized floating nucleus, there is always a difficulty in holding the nucleus and chopping off the nucleus. There is no cortical or epinuclear shield, so you often end up a posterior capsule rupture. The hard nucleus, which involves use of high fluidics, leads to post-occlusion surge, especially in empty bag, which leads to fluttering PC and a PCR, and often due to this and increased zonular stress, and sometimes there's a bag dehiscence also. So when you have associated weak zonules with Morgagnon cataract, there is always a chance of capsular bag dehiscence or a posterior capsule rupture. There is liquefied vitreous, as these Morgagnon cataracts are often associated with older age groups. So you have a lot of bag volume changes with the fluidics, which leads to fluttering PC and a PCR. So coming to the surgical management of the Morgagnon cataract, we start with the incisions. So we at our institute, we use the calibrated incisions. A 2.2 or 1.8 to 2.2 micro incisions are used for the main incisions, and a calibrated side port incision. So what we do is we use a 25 gauge needle with a 500 microns, and we make a long tunnel side port. So this 500 micron is matched with a side port instrument of chopper, which is of 400 to 450 microns, which gives a good maneuverability, which gives less chances of aggression of fluid from the side port and less iris prolapse, and ultimately gives you very good chamber stability. So staining is very important in these cases. You need to have a very good uniform staining. So if you see here, we follow this modified 30 gauge needle technique, which we had published a few years back. So what we do here is we do it under the air. So air is filled through the main port in the AC. A 30 gauge needle is used to enter the AC in from the peripheral cornea. Trypan blue, 1 or 2 drops of trypan blue are injected. It is self-sealing in nature. There is no aggression of air from the side port, and you can have a good uniform stability chamber as well. So in this other video, if you can see, so this is also helpful in cases where the ACT is less than 3, especially in Morgagnon cataracts when you have these swollen lenses. So what you can do here is you can fill the proximal 0.05 ml of the syringe with the air instead of the dye, and when you make an entry through the peripheral cornea, initially the air is injected, which deepens the chamber further, and then the trypan blue is injected, and there is uniform staining. So staining plays a very important role. Coming to the other pearls in capsule rexes is that it should be properly stained, as I've told you. Then you can use a pointed cystitome for initiation. And then when you have initiated, there's a lot of aggression of fluid. So there's always a decreased visibility. So you have to keep on using the OVD. We usually use viscodispersers in this case, which to enhance the visibility and also to inflate the bag and continue capsule rexes. So there's always a difficulty in completion of capsule rexes because of the decreased visibility. And then often if it is associated with the weak zonules, you can always use the help of capsular hooks, which act as an artificial zonules, provide a counter traction, and then you can complete the rexes. So frequent use of OVD for better visibility and bag inflation is really important. Often nowadays we can use flax, which often has partial capsulotomy or incomplete capsulotomy, but it is still manageable as you use the trypan blue for a good visibility, and you can you do a guided capsulotomy along the groove of the rexes in a circular way and complete the flax. You can also use YAGs as a assisted capsulotomy preoperatively and immediately do it in the OR. So this is one of the papers by Chi Sun Feng, where she showed that flax in white cataract, where there were no anterior or posterior capsular tears occurred, but there were risk factors like incomplete capsulotomy, which were associated with Morgagnon cataract, and you can easily manage them if you do a guided capsulotomy. So advantages of flax in these white cataracts are that nowadays you can have fast completion of capsulotomy within 1 second. Then there's the advantage of closed chamber, and then capsulotomy by flax in fibrotic cataracts, it makes it easier as it cuts the capsule over the fibrotic bands. So I'm going to show you a few videos of Morgagnon cataract and how we manage the challenges.
This is a classical case of Morgagnian cataract. Titan-induced staining under air is done using 30-gauge needle. Capsular excess is initiated with milky fluid coming out. There is lesser predisposition to Argentinian sign. With decreased visibility, viscodispersive OVD is injected. With the bag inflated, capsular excess is completed. The mobile nucleus in the empty bag is held by equatorial support. Direct vertical chopping is initiated. Since the equatorial edge is visible, horizontal chopping can also be done. One can see the fluttering of the vulnerable floppy posterior capsule. IOL as a scaffold is being implanted. Now during emulsification, the IOL scaffold is protecting the fluttering posterior capsule. The emulsification is being carried at a deeper plane closer to the IOL without worrying about the posterior capsule rupture. The deeper plane of emulsification gives more protection to the endothelium. The emulsification is completed.
Typical video of a Morgagnian cataract demonstrates difficulty in immobilization of the nucleus due to the absence of corticoepinuclear cushion. The animation showcases the technique to immobilize the nucleus by taking equatorial support of the capsular bag. This surgical video demonstrates how the nucleus is pushed towards the capsular periphery and immobilized. Once the nucleus is immobilized, it becomes easy to chop without any collateral damage. This is repeated for division of all quadrants. This is another case of Morgagnian cataract wherein the nucleus is gently moved towards the equator of the capsular bag and chopping is initiated. Continuous support of the equator is taken till division or chop is not complete. This is repeated for division of all quadrants. So this is another case where it is a case of a small pupil in a Morgagnian cataract, which was preoperatively diagnosed as a subluxated cataract. So if you see in this video, so what we have done is to dilate the pupil, we have used the Malyugin ring, and you can see an empty bag here. So while initiation of the rexes, we were not able to initiate because of the empty bag, and you can see a characteristic halo sign here. So we have to stain the anterior capsule, and then initiation with the cystotome is done on that part of the bag where there was the nucleus, and then OVD was injected to inflate the bag, and then the rexes was slowly completed with, so regular injection of OVD, a viscodispersive in the bag, is very important. And then as the nucleus was very small, It was brought out into the AC, and then again, after bringing it into the AC, IOL was injected into the bag, used as a scaffold.
Sorry to interrupt, sir. We are running short of time.
Okay, so last few seconds only. So other pearls of capsular support in Morgagnon cataract is what we can do is we can always make a large rhexis. As in weak zonulopathy, in Morgagnon cataract, you have less centrifugal force exerted by the weak zonules. So making a large rhexis and anterior capsular polishing prevents any capsular contraction syndrome or a bag IOL fixation later on. A CTR and capsular bag fixation to sclera is also can be done. Thank you so much.
Thank you, Dr. Tushar, for that wonderful videos on how to demonstrate how to operate on a Morgagnon cataract. And like you said, the most important problems are the behavior of the anterior capsule, the lack of support from behind, and the mobility of the nucleus. Have you tried septo precision capsulotomy in these cases? Because
no, sorry, sir. We haven't done Zepto, but we have definitely done flax in these cases.
Okay. I feel for a person who doesn't have flax, probably Septo may also be a very useful actant. I've used it and found it to be very useful in this case.
Great, sir. Great, sir.
Wonderful talk, Dr. Tushar.
Thank you so much, sir. Thank you so much.
Any comments, Arup? Otherwise, we can go to your talk.
Yeah, I think Tushar has done a wonderful job, lovely videos and all that. I just wanted to mention just one additional point. Many situations, it really helps if we use a good dispersive agent to expand the fornix. Just like you see hypermaturity in the lens matter, the zonules also may be weak. And sometimes when there is a little bit of post-occlusion surge, you can see a little bit of zonular mobility. The capsular fornix may come towards the phaco-tip. So I prefer to fill up the capsular fornix with viscoat in some of these situations and then continue with phacoemulsification. And it is a good idea, like if you have to sculpt a little bit, stabilize with your left hand instrument, stabilize the nucleus with the left hand instrument, and then do a little bit of sculpting so that you can start chopping from little deeper aspect of the nucleus. Lovely presentation, Tushar.
Thank you so much, sir. Thank you.
Thank you, Tushar. And I think it was a great idea to use the scaffold technique here. Once you've removed part of it, to prevent the capsule from fluttering and coming into the phaco-tip. Thank you so much. You can stop sharing your screen. I request Dr. Arup. We have introduced Dr. Arup in the beginning of the presentation. Dr. Arup will speak to us about prevention and management strategies of IFIS. Yeah, we've already introduced Dr. Arup, so you can stop that, Lisa. Arup can share his screen.
Am I visible on the screen?
Yes, you are.
You can hear me. Okay, fine.
Yes.
So, good evening, friends. As I was developing this talk, I realized that I do not have that kind of, very scary videos, graphic videos where you see the iris tissue billowing and the uveal tissue prolapsing through the surgical incisions, pupil becoming very small. So in a way, I thought I was on the right track because perhaps I was taking adequate prophylactic measures, diagnosing this, picking up these cases preoperatively properly, and using a good surgical technique to avoid complications. So basically, many of these IFIS candidates present to us as small pupil situations. So it is important to go into the etiology. So we have, the traditional causes of small pupil. And then since 2005, when David Chang and Campbell described IFIS for the first time in patients with BPH on alpha-1 AR antagonist drugs, we have this new entity. So I would definitely like to look into pick up the IFIS candidate from the small pupil scenarios. And these two conditions, of course, may coexist. The traditional cause of small pupil and IFIS candidate may also coexist. So I would like to rule out whether I'm dealing with a hypertensive patient, what are the axial length, is it an elderly patient, the gender of the patient. And then we have a list of medications which are known to be associated with IFIS. So the nurses go through this list before the patient is taken up for surgery. Now, when I have a patient like this with a very small pupil, or I have operated on the fellow eye where I had unanticipated eye phase, I have no second thought about using a pupillary device. Iris hook is my go-to device, and then I have also used iris rings in these kind of situations. But then there are other cases too. So which are those? I always believe in getting the MDPD, that is the maximum dilated pupillary diameter before surgery. And the literature shows a range between 6.5 and 7 millimeter as the cutoff. So if you have a patient whose pupil doesn't dilate beyond 6.5 to 8 millimeters, even those patients who may not be on AR antagonists, alpha-1 AR antagonists, we need to think in terms of IFIS in these cases as IFIS candidates. However, measuring the pupil may not always be it may be quite cumbersome. So what I do these days is take an intuitive pupil to limbal diameter instead of really measuring it. So this is how I go about. This is the maximum dilatation that I've achieved. And this is the limbal diameter, and this is the pupillary diameter. And so I get the ratio. The ratio is 0.58. So if the ratio is anything less than 0.6, I treat this patient as an IFIS candidate and take prophylactic measures. I do not stop any medications on these patients. Though the literature talks about using atropine eye drops a few hours, a few days before surgery, intraocular use of epinephrine or phenylephrine, or newer medications that have intracameral medications that have come up. So let me highlight this my points with this example. So this was a patient same patient that you saw, that the PL ratio was 0.58. So incision construction has to be very, very carefully done. The corneal incisions has to be pretty long. You do not want a borderline incision where the iris gets a tendency to, iris prolapse tends to happen. My superior paracentric incision is not complete, so it is just small, just for me to get access with the chopper into the anterior chamber. And then I'm having said, by this time the patient has become slightly uncooperative, so I'm trying to use intracameral anesthetic for this patient. And incision, if you see clear corneal temporal incision, here again it is very carefully done. It should be long, it should not be short by any means. Long incision, as you need to have a sharp blade, you need to have not a very hard eye. So once I stain the anterior capsule with trypan blue dye, the pupil becomes small. So I realized that I'm going to face difficulties, and I need to be more careful, more alert managing this case. So went ahead with phacoemulsification. So when you perform, the rhexis was easy to perform here. Some amount of viscomydriasis was achieved. I got about 5 to 5.5 millimeter capsular rhexis. Before you perform hydrodissection in these situations, you need to make sure that the OVD inside is burped out. You don't want to be having a very hard eye during hydrodissection. So here you see I'm performing the cortical cleaving hydrodissection. If you see the subincisional iris, it has a tendency to prolapse through the main incision. So you have to be very, very slow. The fluid wave that transmits across the posterior capsule, in front of the posterior capsule, has to be very, very gentle and very, very carefully controlled. And when I try to withdraw the cannula, the hydrodissection cannula, you see, the iris is tented anteriorly. So I engage the iris tissue. So this is another trick. Always stabilize the clear corneal incision with your forceps rather than using a bimanual technique where you support the incision with the paracentric incision and then go into the phaco tip, because you need to make sure that you do not apply too much of pressure in the area of the section, creating a pressure gradient, thereby bringing the floppy iris, the flaccid iris out of the incision. So your zone of work here should be at an anterior plane, preferably in front of the iris, because you do not want the fluid turbulence to be created behind the pupillary area, behind the iris, posterior surface of the iris. Or other option would be to go entirely within the capsular bag and make sure that all these fluidics, all the turbulence, everything is confined within the capsular bag. I would not like to come out with my phaco handpiece in this kind of situation, because every time you come out, the anterior chamber may have a tendency to collapse, and you go into the eye. If the iris is stuck to the incision, you may end up chafing the iris tissue. So one has to be careful. So it is important to top up the anterior chamber with a dispersive OVD in between. So here you see, I have, but the bottle got over. So before you start the complex case, I think it's better to ensure that your fluid is complete, the bottle is full. So it was that basis pouch was over. So I had to come out of the eye and then injected adequate amount of OVD inside the anterior chamber and went ahead again. So never reposit the iris from the main incision. So there was some amount of iris prolapse in the incision. So I went from the side port, I brought the iris tissue, I sort of withdrew it from the incision, brought it inside and deposit some amount of cohesive OVD here just to deepen the anterior chamber, to keep the iris out of harm's way from the phaco needle, and then stabilize the incision with the corneal forceps and went inside the anterior chamber for the subsequent phacoemulsification. It is important to have proper phaco parameters here. Do not have very high fluidics, do not have very high vacuum. We want to do it at a low flow parameter. And as you see here, normally I would have, at chopping, I would have gone up to 650 to 700, but my the parameter settings are at a much lower level. Most of the manipulations are happening at a little anterior plane for reasons which I've already mentioned to you. Now the nucleus is out. So now the main problem starts. There is a thick epinucleus. And as we mentioned after the first talk, when there is a lot of residual epinucleus, pupil is small, particularly if it is an IFIS type of small pupil. In that situation, you have to be, it is quite a tricky situation for us to manage. So I try to remove entire lens matter at this stage, the nuclear matter, enlarge the superior incision, the paracentesis, because it was small to start with for reasons I've already mentioned. So now the bimanual irrigation aspiration goes in. So that gives you more control because you can pull or you can push the iris margin, pupillary margin, thereby giving you enhanced visibility for you to get the residual cortex out. And once it is done on the inferior side, and then the instruments are switched and it is done superiorly. So the cortex also came out without much difficulty. Here something interesting happens. I wanted to use a single piece hydrophilic acrylic lens, and I was more concerned about not damaging the iris tissue. In the process, the lens got flipped. So now here I have a patient with the pupil is small, there's anterior chamber is shallow, iris has a tendency to prolapse out. So should I flip the lens back and keep it into the bag? So I decided that this particular lens is an equibiconvex lens, same curvature anterior and posterior surface. It is a 0-degree angulation lens. The only thing is the posterior square edge is lying anteriorly. So that may perhaps, may not have the anti-PCO effect because the anterior edge is now posterior against the posterior capsule. So I expect an earlier incidence of PCO in this patient. So I just left the lens like that, and patient had done. This is the starting of the surgery. This is at the end of the surgery. This is on first post-op day. A little bit of ace case. I didn't want to see that. This is on the first post-operative, first post-op week visit.
Could you please speed up?
Yeah. So this patient has done pretty well. So friends, I would like to conclude by saying that you must detect the cases properly. IFIS candidates have to be picked up, have an etiological classification. It can happen also in the female patients, so one has to be careful. Pharmacological modulation has an important role to play in small, mild or moderate grades of IFIS. Use an appropriate technique. Don't manipulate the iris in terms of stretch pupilloplasty or sphincterotomy. And whenever you have significant comorbidities, very small pupil to start with or intraoperative, don't hesitate in using a device. Perform a good surgery by maintaining the surgical protocol. Thank you very much for your attention.
Thank you so much, Dr. Arup, for that wonderful presentation and underlining to stick to the basics and the use of OVDs, dispersive OVDs to keep the iris away from your surgical field, that is one step which I found to be extremely important. Can we go on to the next talk? Dr. Soni, you can introduce
Yes.
Dr. Madhu.
It's my pleasure to introduce Dr. Madhu Shekhar, who is currently the Chief of Cataract and IOL Services at Arvind Eye Hospital, Madurai. He holds his MBBS from Rajendra Medical College, Ranchi, and MS from Patna Medical College, and he did his fellowship in IOL and anterior segment surgery from Arvind Eye Hospital, Madurai. He has performed more than 25,000 cataract surgeries, including FLACS, and he has authored many international and national peer-reviewed journals. And he has presented many papers in national and international conference, and areas of interest include A-scan biometry and complex cataract surgeries. Dr. Madhu Shekhar will be talking to us about iridodialysis repair. This could happen intraoperatively, or it could be in a pre-existent iridodialysis. So over to you, Dr. Madhu Shekhar, for your deliberations on this topic.
Thank you, sir, for your kind introduction. I want to thank Dr. Arup, sir, and Cochin Ophthalmic Society for inviting me for this talk. One minute, sir. I'm sharing my screen. My screen is visible, sir?
Yeah, yes, yes. You're visible and you're
Yes,
visible.
yes. Yeah, yeah.
So I'm going to present a simplified approach of iridodialysis repair. As you all know, the iris root is the thinnest and weakest portion of stroma, and it can detach very easily due to blunt trauma or accidental engagement of iris during surgery. It can lead to diplopia, glare, and photophobia. Multiple technique has been described like hangback technique, stroke, and dog technique. So this 3D animation will is for better understanding of this technique. So one scleral flap is made in the along the iridodialysis area, and paracentesis is made opposite to the side of iridodialysis. One arm of the double-armed Prolene suture, 90 Prolene suture, is passed through the paracentesis through the iris root and docked to the 26 gauge needle, which is passed underneath the scleral flap. The process is repeated for the second arm as well. The sutures are pulled and sutures were secured with 5 to 6 knots underneath the scleral flap. One can make a Hoffman's pocket also in place of scleral flap. My first case was a patient with traumatic cataract with nasal iridodialysis. Patient was having symptoms of monocular diplopia and glare. Patient was a driver patient, and so I started my surgery with 2.2 millimeter incision. Paracentesis was made 2 millimeter, 2 clock hour away from the main incision. And iridodialysis area was supported by 2 iris hooks. A dispersive viscoelastic elastic was injected in the anterior chamber. iris hooks was introduced to support the hydrolysis area. After completing rhexis, nucleus was emulsified. Cortex was aspirated and single piece acrylic IOL was placed in the bag. After completing surgery, hooks were removed and intracameral pilocarpine was injected to constrict the pupil. Conjunctival peritomy was made along the area of hydrolysis. Bleeders were cauterized, and 4 into 4 millimeter partial thickness scleral flap was created in the area of hydrolysis. One can make Hoffman's pocket also in place of scleral flap. One arm of the double-armed Prolin suture, 90 Prolin suture, was passed through the paracentesis. 26 gauge one needle was introduced 1.5 millimeter behind the limbus underneath the scleral flap. The needle was docked in the 26 gauge needle and externalized beneath the scleral flap. The process was repeated for the second arm of the double-armed needle as well. Sutures were pulled. Cyclodialysis spatula was used to reposit the iris to check the shape of the pupil. And the sutures were secured with 5 to 6 knots underneath the scleral flap. After checking the shape of the pupil, there should not be any ovalization of the pupil. Conjunctiva was reposited and sutured with 80 Vicryl suture. This is the first day post-op of that patient. My second patient was also having traumatic cataract with hydrodialysis with posterior synechia. Case was started with phacoemulsification. Cyclodialysis spatula was used to release the synechia. 3 iris hooks were used to retract the iris in the area of hydrodialysis. While doing rhexis, capsule rhexis, jonodialysis was noticed in the area of hydrodialysis. So the same hooks, iris hooks, was transferred to the capsule rhexis margin to support the jonodialysis area. Nucleus was emulsified, cortex was aspirated, and 11 mm as a Jones was weak, so 11 mm CTR was inserted in the bag. Single piece acrylic IOL was placed in the bag. Similar to the first case, the one arm of the double arm Prolin suture was passed underneath. Care was taken. It should be near the root of the iris, close to the root of the iris. Iris was reposited to check for the shape of the pupil. This procedure was repeated for the second arm as well, and sutures were pulled out and secured with 5 to 6 knots. So this simple mattress sutures does a wonders to the patient for the rest of their life. Both the patients were complaining of glare and double vision, which was corrected with this hydrolysis repair. So take home message is this repair should be attempted after placement of IOL placement to avoid ALC damage. Care should be taken not to engage the corneal tissue while inserting the needle through the paracentesis. Sutures should be passed close to the base of iris to avoid avulsion of the pupil. tightening of suture knot should be titrated to check for that. Thank you for kind attention.
Thank you for that wonderful talk, Dr. Madhu. It is a lovely demonstration of how to fix the iris, the iridodialysis back into place. One thing I've noted is that you've been very gentle when you enter with the 26 gauge needle, which is used to dock. If you push it forward, you can make the dialysis worse. So you just supporting the root with the 26 gauge needle and using more of the pressure of the proline suture rather than pushing the 26 gauge needle forwards. Otherwise, it could lead to even more dialysis. And I have one more question. Why did you choose the 11 millimeter endocapsular ring in that case?
It was a normal axial length case. Quite diameter was normal, so I have chosen 11 millimeter.
Okay, it's a slightly smaller. I think we could go for 12 millimeters or so, because if it's a normal.
But it was only a localized dialysis, no? It was only a very small area of zonal dialysis.
Yes, sir, it was localized.
I think 11 can be good enough. Yeah. Arup, any comments, or can we go on to the?
I think Madhu has done a wonderful, demonstrated a very good case and very well done. So Madhu, supposing if the dialysis existed in the absence of a visually significant cataract,
yes, sir,
what would you do? Can you apply this technique?
Then we have to look for this one, sir. We have to protect the anterior lens capsule. We can introduce either that foldable contact lens or ICL also in the anterior chamber to protect the, because this procedure can damage the anterior lens capsule.
Exactly. Yeah.
So you have to protect the anterior lens capsule if you are not going for cataract surgery.
And for the benefit of all the young ophthalmologists here, can you just mention how much millimeters away from the limbus would you go in with your 26 gauge needle to get the exact root of the iris?
Around 1.5 millimeters behind the limbus.
Thank you so much. Lisa, can you share the screen for Dr. Lee, and Dr. Arup, can you please introduce Dr. Moonwai Lee to the audience?
So it is really my pleasure to introduce my good friend, Dr. Lee Moonwai. His father, Dr. Lee, is again a very good friend of mine. So Dr. Lee graduated from the University of Manchester and started his ophthalmic training in United Kingdom. He went on to advanced specialist training at the SNEC and subsequently completed a VR fellowship at the Lions Eye Institute, Western Australia. So he basically is not only a great anti-segment surgeon, but he is a VR surgeon too. A great combination. Currently, he is the medical director at LEC Eye Center in Ipoh, Malaysia, and also the chair of the Malaysian Society of Cataract and Refractive Surgery. He has published many papers in peer-reviewed journals, as well as contributed book chapters to allied health textbooks, and also authored an eye care book for the general public. He is a reviewer for the AJO, Asia Pacific Journal of Ophthalmology and Malaysian Journal of Ophthalmology. Dr. Lee has been an active educator in the Asia Pacific region and has conducted numerous courses as well as demonstrated live surgery at the annual Congress of the Asia Pacific Association of Cataract and Refractive Surgeons, the Asia Pacific Academy of Ophthalmology, and the Asia Pacific VR Society. So, Moonwai, it is really a pleasure for us to have you here, and we also plan to have you here for many more meetings in the future. Over to you, your talk.
Well, thank you very much, Arup. And good evening to all in India. And it's my privilege indeed. And thank you for having me involved with such a prestigious group of ophthalmologists here. Thank you to the Cochin Ophthalmic Club and Kerala Ophthalmic Society. So just let me start by sharing my screen. And I'm just going to be switching gears a little bit because I think I have myself already got a lot of revision listening to those talks preceding me. And I've actually now switching gears a little bit and talk not so much about how to manage all those tough situations, perhaps how to manage expectations of our patients now as we move towards the presbyopic age. So presbyopia, I think, can we argue whether it is the holy grail of ophthalmology? I think it's something that we all strive to actually be more glasses independent as our patients demand that. So this is just a quick survey that was done in 2018 ASCRS. As you know, every year they have a different survey being conducted with different questions. And this was actually asking in terms of the use of presbyopia correcting IOLs. And you find that that is actually a very low proportion of surgeons that actually do it. So 9% in the US and slightly more outside of the US, 11% out of our whole cataract load. So what is it really that's stopping us from adopting the presbyopic correcting IOLs? So I think this was a survey done by Alcon of about almost 200 surgeons. They found that the most common reason why surgeons do not want to implant these lenses, I think, is because there are a lot of visual disturbances that have been associated with that. And there's a lot of chair time involved, and the patient selection has to be critical. And, you know, those of us who are doing these type of lenses will have maybe 8 or 9 very happy patients, and you got one unhappy patient, and that one will sit in your waiting room, and it's always a nightmare to see them sitting there waiting to see you, because it's a long time that you have to spend with them. So these halos and glares and this dysphotopsias are really an issue that a lot of the stakeholders that actually pay for these lenses, and as well as the ophthalmology surgeons as well that have been surveyed again in this different survey, put as top reason why, you know, the adoption of such lenses are actually not widespread. So we are very familiar now, if you talk about multifocal, or now we have trifocal lenses, the diffractive IOL design has really been one of the very popular platforms that we have been using. And the principle of which is just using a diffraction grating, which actually splits the wavefront into different focal points, and therefore giving us intermediate, distant, and near vision, but with actual compromise of all these halos and starbursts, reduced contrast, and is really sensitive to tilt and decentration, which will give all the visual disturbances, despite all the 20/20 and very good near vision, and we still have very unhappy patients. So this is actually the Alcon VVT lens, is what I'm going to be talking about a little bit, sharing my very early experience. And this technology that has been shared by Alcon here is quite different in the sense that it doesn't split light. I'll go into that a little bit more, but they call it the X-wave technology, but essentially it does not split light, and it actually elongates and shifts the wavefront of light to actually give you the extended range of vision. Of course, again, it is still a compromise. And as we know that, you know, there are so many presbyopic correction intraocular lens solutions there. So obviously, when there's so many things to try and solve one problem, there is no perfect solution yet. So then again, there is a drawback in that this technique or this technology does not give you the near vision if the patient really desires it. So the Alcon VVT lens has just come into Malaysia about a couple of months ago. So I'm just sharing my very early experience. I think I'm not sure. I think perhaps India might already have it, or I know the US colleagues have been talking a lot about it. And essentially, it's very similar to the popular Acrosoft lens. It's based on the Acrosoft platform, and it looks very similar to the Acrosoft IQ lens, which, you know, Alcon has been using for many years now and has millions of implantations worldwide. So this is how the lens looks like. So if you didn't put these labels here, you will almost say that the two lenses look identical, because they're actually based on the Acrosoft platform with the stable force haptics and the square edge. And the only difference you will see is the central 2.2 millimeters, where they have these, what we call transition elements. So there is a small change in the actual elevation. There's a little plateau there, which is about just a micrometer high. And this actually stretches the wavefront. I will show that in a different image afterwards. And the other transition element is actually a change in the curvature in the central 2.2 millimeters, which helps to shift the wavefront. So how does that work? So if you look at this image here, a side profile of the lens. So the anterior part of the lens is where these transition elements are. So you have a wavefront of light that hits this transition element. The first transition element here, as you see, will actually slow down the light through the center. So the light from the side actually moves faster than the light through the center, and subsequently it actually causes an elongation of the actual wavefront, and it forms a little column of focal points, which gives you the extended range of vision. But what actually happens is this extended column, part of it will then fall behind the retina and becomes out of focus. So the other transition element, which is the change in the curvature at the anterior surface in that central 2.2 millimeters, will then shift that wavefront forward so that what lands behind the actual retina will come into more focus and gives you the extended range of vision. So just an illustration here. So again, how this one works for distance, it gives you as the retina here a focal point there. And because of this whole column, it gives you good intermediate distance vision as well. It gives you what they call functional near vision, means that if you want to go for the really small print, it's not going to give you that type of vision. But does this lens then have a role? Does it deliver? So there have been 2 large RCTs done already, one in the US and one globally, and these were the studies that were used for the FDA approval. So you can see here over 200 eyes in each arm, and they're actually comparing about 100 in each arm of Vivity versus the monofocal Acrisoft IQ. Looking at the standard parameters, essentially what you want from presbyopic correcting IOL, of course, is to give you distance, intermediate, and near. And they found that over here, the blue bar is the Vivity and the gray bar is the IQ. They're very similar, very close to 6.6 vision, 20/20 vision for distance. For intermediate, it does better than the actual IQ lens. As you know, the IQ is a monofocal, it's a pure monofocal, so the Vivity should do better. And it, of course, also does better than a monofocal in terms of its near vision. But as you can see, there is a drop-off. So at 40 cm, you get about 20/32, which is probably, if you use the N notation, around about an N8, perhaps an N6. So the 2 studies actually also looked at using questionnaires to evaluate the disturbance profiles in terms of dysphotopsias. As we know, early on I shared that that's one of the main reasons why surgeons are not taking this technology on. So what this graph essentially shows the percentage of patients that were not at all bothered by visual disturbances. And what you like to see is that, as we know, monofocal lenses are the ones with the least amount of visual disturbances because there's no light splitting, but it doesn't mean there's no visual disturbance at all. But as you can see, the blue and the gray bars are pretty much matched, whether it be in the US or the global study, which means that it at least with this presbyopic correcting IOL, the Vivity, it matches the monofocal Acrisoft IQ in terms of visual disturbances. So it's like a monofocal lens. If you look at the defocus curve, this is what we want to see. With a monofocal, you got a sharp peak at distance and then a drop off as you move towards near. So you get a nice plateau there, which is, of course, if you get a higher plateau, that would mean that you get better near. But as you move towards intermediate and you go towards 40 cm, then you see that the actual vision does drop off, but it does do better than the IQ. And this is the same rate in the global or the US market studies. So what is my experience so far? As I mentioned, we've only had it for a couple of months. And the reason why I've decided to talk a little bit about it is because I'm actually quite excited about what I've done in this first 10 eyes of my patients. So bilateral patients that I've done, 6 eyes with what we call DFT015. Now, you have to ask Alcon why they named their lenses this way. But I believe that depth of focus, that's what it means. T0 is actually non-toric, and 15 means whatever. They have to actually ask Alcon what it means. But 6 eyes were just standard Vivity lenses. 4 eyes will have the toric component as well. And the good thing about what Alcon have done this time, at least to Malaysia, they have actually launched both the standard the lens as well as the toric component, because as we know now, we need to actually correct all the astigmatism when we treat presbyopia. And I use Barrett formula as a standard, both the universal 2 for the spherical calculation and the toric calculator as well. And in this case, there was no opportunity to do any personalization, and they decided to just use the manufacturer's A constant. So the standard inclusion criteria and exclusion for all these types of simple studies, bilateral cataracts, visually significant, of course, no other ocular pathology. And if they had any intraoperative complications, they would be excluded. So essentially what I wanted to look at is just the range of vision, the distance, intermediate and near uncorrected. Look at how the lenses behave in terms of this predictability and stability over a month. Do a defocus curve and a questionnaire and just ask about visual disturb, or rather have a record of visual disturbances that the patients might report. So this is a typical cataract population, and small numbers, as I said, but nothing extraordinary in terms of axial length, quite standard, and not too bad vision. I think it ranged between about 20/30 to about 20/60, 20/70 vision. And what's reassuring is they get good uncorrected vision, both at 1 week and at 1 month. So this is converted to logMAR. So we're looking at the uncorrected distance, intermediate and near vision. We find that obviously the near vision is not as good as reflected in the global studies and the US study as well. But what I did find that intermediate vision didn't do as well at on the seventh day, post-op 1 week, but it did improve significantly when it got to 1 month. And as I show after, there is a little bit of a myopic shift, which may actually help with that. So good visual outcomes overall. So 0.16 is around about 7.5, 6.9, so it's about 20/30. And at 1 month, the uncorrected VA, if it's binocular, because now these are bilateral implantation, as we know, these type of lenses always work better as there's a summation effect, and this is indeed shown very well, where you get very good vision, almost 20/20 with distance vision, and in fact better than 20/20 on average, and in the intermediate range, and very functional 0.28 logMAR is around about 20/30, 20/40 type of near vision. So it's about N8, and it's good font for newspaper. Like I mentioned earlier, this is some myopic shift I found between 1 week to a month. So what happens is that this is the mean refractive spherical equivalent. As you see, there's a little bit of myopic shift towards the 1 month period, and all of them were, the small numbers here within a quarter or a 0.5 diopters of the target. I think Barrett formula actually gives us that. You should expect beyond 80-85% of eyes less than 0.5 diopters of target. And this is what I liked about this lens, is that the binocular, the defocus curve actually looks better. I think you see the blue line here with all my 5 patients, they actually did very well in the medium range with the distance vision all the way to intermediate. In fact, when you go up to about -2, which is about 50 cm, and -2, -40, it's about 40 cm. Of course, you get a drop off there, but this were all very functional near vision that they could get. Mobile phones, no problems. I did a quick questionnaire. There's many questionnaires available. I tended to use the VF14 for a lot of my presbyopic patients. I find that it does have very practical use in my group of patients in the terms of activities that they ask about. And essentially, it gives you a score out of 100, and one of my patients scored it full marks, but most of them were close to 90% in terms of their satisfaction scores, or rather, in terms of the activities that they're able to do with these lenses, day-to-day activities, and such things as, if you look at the way they actually grade this questionnaire, 1 it being no difficulty and 5 being completely unable to do it, most of them actually fell below the number of 2, which is just a mild difficulty. Obviously, small print is difficult. Reading newspaper, not so much, but a lot of it will just mainly no difficulty whatsoever, particularly the driving in the day. Driving at night slightly, but not so bad. And what was reassuring, that none of them actually reported visual disturbances. I mean, this is non-prompted. I didn't ask them specifically if they had halos or glare, but they were actually a month out and did not report any sort of difficulties with their vision, particularly with nighttime vision. Just a quick case, I have a 60-year-old gentleman. Mainly complaint was because he did drive a fair bit and it blurred vision, finding difficulty with driving. And this is the type of vision. He had a 3+ nucleus. And at the moment, what were his visual requirements? I think when we talk about presbyopic correcting IOLs, we have to take time to sit down and discuss with the patient and find out what their individual needs are. So he's retired, likes to drive, he's still very active. And we are in various states of lockdown over the past 12, 15 months at different times, but he still does his regular exercise, doesn't use so much computer, but uses a mobile phone quite a lot. So he was motivated to be glasses free because he doesn't like it, for one. And now for the past months, because of COVID, we have to wear the mask all the time, and he's got a high nose bridge, and basically his glasses were fogging up all the time. So this is just a quick video, just to show the lens. I think if you look at it, even through the microscope at this angle, you can see it looks pretty much like an IQ lens, and it's prepped the same way with the D cartridge. And I like to use the AutoSert, and this is what I've used here with a wound-assisted technique through a 2.2 millimeter incision. And it just goes in very much like an IQ. What I just wanted to show is that there you go, there's a little element in the center that you can see the transition elements with the central 2.2 millimeters with that plateau. So this is a toric lens that's been aligned with the Varion, and essentially it behaves no different from an Acrosoft. But what you can see at certain angles on the first day when I looked at it, looking specifically for this, if you do a quick once over with the slit lamp, you probably won't see any difference, but you can actually see that central circle and the plateau as well as the central 2.2 millimeter ring there. But this ring doesn't give you the actual dysphotopsias because it's actually just a transition element. His vision at first week wasn't as good as at first month, but I can say that, you know, he had good functional vision. He had both eyes done just a few days apart, so this was the refraction as such. As you can see, move on to the first month, and you can see there was improvement in his vision, and he actually did very well binocularly. He was 6.6, and he was the one that scored the lens 100% because he had very, very functional vision, and even got N5 with this, which is about J3, and very good near vision as that. So really, I think, in summary, I think it's very easy to use. I found the Vivity just like the Acrisoft. Patient selection for any presbyopia correcting lens is key, and you have to find the right patient to match with the right lens, and that's where the time is taken in this type of endeavors with multifocal or presbyopic lenses. So it gives good distance and intermediate vision, and I would call it still functional near vision. No doubt I had one patient out of the 5 that did so well. Perhaps there have been actually different colleagues from America have talked about using it in other eyes with some mild glaucoma, perhaps early dry AMD, mild diabetic, post-refractive even perhaps, because there is no splitting of the light and the drop in contrast is perhaps not so bad, and the dysphotopsia is not so bad as well. And definitely I found the 2 eyes are better than 1, and binocular summation works much better with this lens to give them good vision. So really, I think the crusade continues for that holy grail. I think the Acrisoft Vivity goes away to answer some of those questions, but definitely is not the finished article because there is still some way to go in terms of getting that really good near vision. But then again, it still has a role because it does not have those dysphotopsias, which are actually a major issue when we want to adopt these lenses. Well, thank you once again for the opportunity to share. And I hope there's been something that can be a bit more useful, not so much about managing complications, but about using a different presbyopic correcting lens. Thank you again for your time.
Thanks a lot, Moon. It was really very informative for us. Actually, our country, I think when I inquired with them, they're not going to launch it before this year end.
Oh,
so
right.
It's good that you had an early exposure to this lens. So do you feel that this lens is going to shrink the list of contraindications for the trifocals that we have been accustomed to over the last few years?
Yeah, well, I think I've been very accustomed to the panoptics and the other trifocals as well, and I think they work well. I think I have it still in my armamentarium for those that really want the good reading. I find that the panoptics will probably do better than this. But, we still have those where come back, they say, I can't bear with those halos, and, you might end up having to explant these, and it's really no way of finding out which one is going to get that and which one won't. Even though, like I mentioned, 9 out of 10 may be happy, and you got that one unhappy patient that sticks in your mind. So I think this will have a role. So I will always tell them that, that this will not give you the near vision that you desire, but I think there are also possibilities of perhaps going a little bit with a myopic side, with the non-dominant eye, perhaps half a diopter, because right now all of them I've targeted at ametropia. That may give them that additional reading, so that with more experience, I think we could tell.
Your results were slightly on the myopic side, the prediction error. So
yeah, at the moment,
do you think it is because of the A constant has to be further optimized?
I think so. I think, I was thinking whether I should just use my IQ, a personalized constant, which probably would make sense. It's the same platform, but I thought we just use the manufacturers and see what happens. I think that will have to be optimized, definitely. Yeah. And I think if you were to target, I would probably go for the first minus, I think, rather than just closest to ametropia. Because, the distance vision, I think, can be quite forgiving because it's got that long column for the distance and intermediate, which may be quite good.
Okay.
Thank you so much, Dr. Min. We are waiting to use this lens in this part of the country.
Right.
Can you? Yeah, it's my pleasure to introduce Dr. Arup Bhaumik. I have watched his videos at various levels with so much of fascination. He has many publications in peer-reviewed journals. He won the grand prize in the ASCRS in Boston 2010. And again in ASCRS Innovative Session in 13. Best Video in ESCRS 2013 and the IRSA Gold Medal in 2015. Dr. Arup is going to speak to us on a new way to handle subluxation. Welcome, Dr. Arup Bhaumik. Please share your screen and start your presentation.
My screen is visible. Am I audible?
Yes, both. Yeah. Yes, please go ahead.
Okay.
Yeah.
Thank you, Srini and Dr. Arup Chakraborty, giving this opportunity. And once again, thanks, Coaching Ophthalmology Club, for wonderful webinar. I just want to discuss or give my thought regarding a new approach to handle subluxation. I have no financial interest to disclose. Generally, if the subluxation is more than 3 clock hour or more than 90 degree, you has to have to fix the capsular bag for the long-term stabilization. Even in the subluxation where there is a long-term progression of subluxation may be there, then we have to fix the capsular bag, either arm segment or by the Sioni ring. Or when the subluxation is more, we have to use 2 arm segment along with the CTR or with the Sioni ring with the double ring to fix the capsular bag. The concept is so far is to fix the capsular bag and implant the IOL into the capsular bag. And when it is not possible, we has to the subluxation more than that, and whenever in the surgery think that it is not possible to fix the capsular, stabilize the capsular bag or fix the capsular bag with the sclera, then we used to sacrifice the capsular bag and go for IOL scleral fixation or blue dial or interscleral fixation as per the surgeon's choice. So I am going to share some thought regarding this. This is a grossly subluxated case. There is a generalized capsular weakness. This is all. There is a lot of phacodonesis, and the lens is absolutely unstable. So it's always important to do the good capsular rhexis, and it is the most important stage to deal the subluxation, and this is the first battle you have to win to do a good capsular rhexis and with a good size. So it is important to inflate anterior chamber as frequently to do the capsular rhexis, and whenever you feel the rhexis is not possible, you have to put some kind of counteraction in capsular rhexis. But in that case, I am able to do a reasonably good capsular rhexis with a reasonable size. And as you know that the capsular subluxation, you have to stabilize the bag anterior posteriorly, and capsular hook is the best to stabilize the capsular bag. Because if you use the iris hook here, it is sometimes it can give unnecessary pressure to the capsular margin, and capsular margin can turn. Here I am using MST capsular hook. This is fantastic, but these are the MST capsular hook. It's a long flange, go up to the equator of the lens, and I using one metal design capsular hook. And the idea is this is a hard cataract that is quite a good debulking and do a chop, and I able to remove one piece from the capsular bag. This is you have to do in every case when there is a hard cataract with the subluxation, and I could always give some viscoelastic to protect the anterior chamber, because most of the cases in this type of cataract we have to do the anterior chamber phaco or supracapsular phaco. And gradually with the slow motion phaco, I able to finish, remove the half of the quadrant. And this stage I want to put the CTR to stabilize capsular bag horizontally. This is very important, and this is a very good dictum. The timing of the capsular endocapsular ring is as late as possible, as soon as you must. This is a wonderful dictum for the implant the capsular endocapsular ring for the subluxation. So it is as late as possible, as soon as possible. So I decided to go for the I make a capsular flap here and here, and I want to stabilize the capsular bag with the two arm segment. Suddenly I decide, why don't we try this something different in this case? I just make a puncture through this with the MBR blade, and I try to do something different. I just do a neat suture guided blue dial technique for this particular case. This is not actually blue dial. This is intrascleral fixation. I plan for this. I just bend the tip of the axis of multipiece lens to tie the knot in the leading haptic as well as the tailing haptic. The advantage is that whenever you try to do the handshake technique into the where the capsular bag is also there is a lot of tumble of the haptic. You can see there is a tumble. Even in these cases, there is a tumble. But if I try to do the handshake technique is this with the forceps, there is a lot of tumble. And I just implant the capsule, I will over the capsular bag and do this little bit vitrectomy and capture the optic into the capsular bag. The concept is this: I fix here the lens, not the capsular bag, and I attach the capsular bag with the optic. This is a reversing the fixation. Generally we fix the capsular bag with the sclera, but here I am fixing the lens and attaching the capsular bag with the sclera so that it got stabilized, long-term stabilization. So next case, I just want to say another case. This is a case where the microspherophilia. Even if you try to do a fixation with the Sioni segment or Ahmed ring, there is a lot of gap from here to from the pars plana or the equator of the lens. Yes, the lens is very smaller size. So I plan to do the same technique in this particular case. You can suggest I put some irrigation in the pars plana, and I'm making some just phosphorating the lens. You can see there's a lot of gap from the equator of the lens. So it is not wise to give a fix the bag with the Ahmed segment or the Sioni ring, because anytime back can shrink it or back can dislocate it. So I follow this technique. I do the rexis, and this is softer cataract. Emulsification is not a problem. I stabilize it with the capsular bag with the capsular hook and put the endocapsular ring to stabilize the bag in the horizontally. And as there is a lot of space, I just try to do in this particular plan to do the I make a conjunctival flap here, and again puncture the MBR blade in the sclera. And I do the same technique I'm doing. Here I am not using the suture, as there is a lot of space. I using forceps to exercise the haptic of the IOL. And same thing, I exercise the haptic again, and now I capturing the optic with the rexis, capturing the optic, and same time I am exercising the haptic of the other side. So now the lens is captured with the anterocapsular rexis, and lens is at the center of the pupil. So I again fix the capsule as usual matter, and with the WWOR chariot tunnel, and I'm not using any glue here. Is a as shown by Gabor shared here, and I do little bit of visco removal, and the lens is absolutely centered. And this is a almost 8-month post-op picture of this lens, and this is absolutely stable. So what is the advantage of this technique? Advantage over back fixation is a long-term stability. Sometimes we did almost 10, 12 years back when I fixed that there is a suturolysis, and again you have to remove the back capsule. There is a chance of suturolysis in the prolene suture. If you use a 10-0, there will be definite suturolysis over the year. Even in a 9-0 long-term follow-up, I don't know. And now the Gore-Tex suture is available in the world market, not freely available in Indian market. There is some scleral erosion with the Gore-Tex. So this is it is an advantage. Is a long-term fixation is assured in this particular space. And advantage over blue dial is here we preserve the capsular bag. This is actually which is needed for the cataract surgery. And as the capsular bag is there, we often see a lot of phacodonesis in the blue dial or interscleral fixation or scleral fixation, which is the main problem of the blue dial or interscleral fixation. In this type of technique, there is absolutely no phacodonesis. So what is the advantage? It's a over blue dial. Blue dial is a aphakic blue dial technique. Here I am doing the interscleral, what is pseudophakic blue dial technique. We make a aphakia, then we implant blue dial. Here we are keeping the capsular bag, the concept, and making the glue. Thank you. Thank you for your giving the opportunity, and thank you for your listening. And I just want to know from Arudha and other panelists from this technique, whether there is really any advantage. I think there is a lot of advantages technique, but I want to hear from you whether there is any advantage or not.
I have got a question, Dr. Arup. How do you ensure the space between the iris and the intact capsule when you put in your NVR to make the entry?
When you put a NVR, you should be towards the macula, so you will not injure the capsular equator. Again, you have to use the blunt tip. In the first case, I am not sure, so I am using suture because the suture is a give me little bit of space for the control of the lens crumble in that area over the capsular area, and so it will be the control. And the next case where the microscopic there is a lot of space in the equator. So I go 2 millimeter from the limbus, and from the initial puncture I go vertically. And when I introduce my forceps, MST forceps, I go the horizontally, and sometimes I keep my visco cannucula to press the capsular back slightly below and introduce my forceps over the capsular back. So far I did almost 12 cases, and I don't find any problem. The one case is I injured the capsular equator with the forceps. So after that, I always press with the visco cannula or spatula, little bit press the capsular back posteriorly and introduce my forceps.
So Arup, one last question is what lens are you using these days?
I am using now. This is the first 2 cases with the acris of multiples, but now I am using sensor multiples.
Okay. So see what our plan is, after the talks are over, because Dr. David Chang has just a limited period of time that he'll be here.
Yeah.
Then we'll have a panel discussion. Whatever questions that have come up in our minds and have not been considered, we'll have a panel discussion. I think that is what do you say, Sai?
Yeah, we'll go ahead with that. Yeah. And after Dr. Partho's talk, in case our time is short, we can, if it is okay, we can request Dr. Irfan to just hold on.
Okay.
And David can finish his talk, and then we can continue.
Yes.
Sony, can you please introduce Dr. Partho?
Yeah. Well, ladies and gentlemen, it's my proud privilege to introduce a man who doesn't need any introduction actually to all of us here. Dr. Partha Biswas, a great teacher, a man with a smile always, and another phase of his was revealed during the court-martial in ophthalmology in the All India, where he was the cruel public prosecutor. Well, Dr. Partha, he is the chairman scientific committee of the All India Ophthalmic Society from 2020 to 22. Chairman of the Academic and Research Committee AIOS for 2 terms, 14 to 17 and 17 to 19. And the number of awards he has received from the Colonel Rangachari Award, the oration at the Vidarbha Ophthalmic Society, APSRS, and the list goes on. And he's a reviewer of ophthalmology, IJO, and seminars in ophthalmology, IOVS. And he's got a lot of publications in IJO, ophthalmology, and a lot of international presentations and guest lectures, almost 68 in this national conferences. And like I said, he's been conducting court-martials in ophthalmology with a cruel face, 75 sessions. And he's a postgraduate teacher and evaluator and a guest faculty in many conferences. And ladies and gentlemen, this is Dr. Partha Biswas to you. Over to you, Dr. Partha.
Thank you very much, Sony. Thank you, Cochin Ophthalmic Club, for the continuous learning that you afford to us and everybody. Wonderful. Thank you, Sai. Thank you, Arup. And thank you, the whole team. Gopal, thank you so much. So I will... traumatic cataract is something that I feel that every cataract surgeon should have a learning as well as something that has to be learned and that has to be done. And this is a small video that I'm going to play, and it's a little bit of learning to my colleagues, to my junior colleagues, whom I have been teaching the traumatic cataract repair, because each traumatic cataract is a unique situation in itself. So let's go on to this video on the traumatic cataract. So the traumatic cataract can occur in everybody's career, and it just takes the guts out whenever it happens. So as any learning surgeon, it's important to remember that nearly 55 million people all over the world get affected by traumatic cataracts, and the trauma to the eye can devastate nearly 1.5 million eyes every year. So having said this, this was a WHO report, and whenever we do cataract repair for trauma, it can be done by 2 approaches. It can be done by the anterior limbal approach, or it can be done by the posterior pars plana approach. So when is it anterior limbal? When it is the pars plana. So if it is anterior limbal, then it has to be, you have to be sure that there is not much of disturbance in the posterior chamber, and there can be a cataract with a subluxation, and the whole gamut of investigation should reveal that the anterior limbal approach is the first one to go ahead with. However, if there is a dehiscence of the posterior capsule, if there is lens matter in the posterior chamber, it is the pars plana approach that has to be taken up. But whenever a cataract comes in, a traumatic cataract comes in, a whole investigation must be done. So let us take you through one of these cataracts, which you can see is a very deep brown brunescent cataract and nearly half popping into the anterior chamber. So you can see that there is a little bit of an iris defect as well. And we place in the high molecular weight viscoelastic to make space And while making the space, what we need to do in this case is also the trypan blue, which has to be smeared onto the anterior capsule so that you can get a rhexis in this. At times, such hard cataracts, you might really feel that why not just take it out and put in a scleral fixated or a glued IOL. But the posterior capsule is something that must be retained. So once you have put in the hooks, the capsular hooks, and then the CTR, and you can see that the centration of the whole capsular bag can take place. But the next part, which becomes very, very difficult, is the nucleus management. And in such a such a hard cataract with subluxation, it is the anchorage of the capsular hooks which makes it relatively easy. You need to take off one pie at a time, and gradually the whole cataract with a straight or a direct chop can come out. So you have an intact capsule here. Therefore, the best thing would be to place a single piece lens inside the bag. And once the single piece lens is placed inside the bag, then it's important to see that there is definitely a luxation, and the Cione ring has to go in to center the whole capsular bag complex. And once the Cione ring is optimally pulled and the centration has taken place, then things definitely look to be quite easy. However, everything said and done, in such cases, it is also important that the vitreoretina surgeon should be on a standby and definitely should be a part of the whole discussion or the whole planning whenever it goes. And we have our senior vitreoretina surgeon who is there, our anesthetist who is there. And this patient is a patient whom we definitely possibly would require a posterior segment approach. However, once the planning goes on, we definitely feel that maybe we could try the anterior approach, but if it requires, then a posterior pars plana approach can also be done. So if we first enter into the anterior chamber, and you can see that there's a huge scar and there's a lot of synechia right with the capsular bag to the remnants of the cortical matter, which is in the anterior chamber, and also the iris tissue. So staining is very, very important, and you'll realize this as we proceed with the surgery. So trying to take off with a blunt spatula is really not going to work. So here is the place where the vitrector comes in extremely handy, and you can remove the amount of additions very well without traumatizing any part of the rest of the tissues which are already traumatized by the injury. So as we go ahead and as we gradually try and take off the additions and the cortical matter, which is relatively soft, we remove the nucleus part. And what we do find here is that we still have the anterior capsule there, and we still have a scaffold on which possibly we can place the intraocular lens. So we place in the intraocular lens, and there is still, as you can see, a stump over there with the addition, and the lens, as you can see, is well centered. So here the luxation was not there of the bag, and thereby the centration is very much there. To take off that remnant, it requires not the vitrector now, but a thick forceps, venous forceps, venous scissors, which will take it off. Now, what is going to be the outcome? So first and foremost, we do have some amount of vitreous into the anterior chamber, but no cortical matter or nuclear matter has fallen in, thereby saving the posterior, which we are surgeon, the possibility of intervening. So now, once everything is done, it's also important to evaluate the whole scene and to remember that an eye with a trauma, a full evaluation is what is required, both the anterior segment and the posterior segment, as well as the adnexa. Ultrasound needs to be done, and in special cases, the CT scan or the MRI needs to be done. Every step must be well planned, and plan A and plan B should be there. Instruments have to be as appropriate as possible, because the surgery itself should not inflict more trauma to the tissues than is actually necessary. The strength and integrity of every tissue that has survived the trauma should be duly respected. And that is important because even a traumatized eye can regain a 6/9 and 6/12 vision. And this is a whole time vision for such eyes. Thank you very much for your patient hearing.
Thank you, Dr. Partha, for that wonderful demonstration of dealing with a traumatic cataract. I'm sure we learned a lot from that. Any questions to Dr. Partha?
Nice videos, Partho, as always. A lot to learn from that. Any questions for Dr. Partha, or we can? I think we have just time for Dr. Sohail. Before 8:30, we have 20 minutes. Arubda?
Yeah, we will have Dr. Sohail and
Yeah. So Dr. Sohail is a comprehensive ophthalmologist. He's from Nanded in Maharashtra. He's the winner of the BOA quiz, pre-conference quiz in the Small Incision Cataract Society and in the IOC 2020 in Gurgaon. He has also won the Best Video and Best Technique Award in the Big Standoff Challenging Video Symposium. He is also the winner of the first prize in the World Webinar in Cataract and Refractive Surgery in the Cataract category. So another young star in the phaco cataract horizon in India. Welcome, Dr. Sohail, for your talk.
Screen share. Am I audible, sir? Hello?
Yes. Please go ahead. You are audible and visible. Please go ahead.
Okay, sir. Thank you. I am extremely thankful to Dr. Arup Chakravarti, sir, and the Cochin Ophthalmic Club for inviting me for this meeting of expert ophthalmologists. In fact, Dr. Arup Chakravarti, sir, is one of my mentor in cataract surgery. Through this 10-minute presentation, I am going to present a successful recipe to deal with all kinds of cataract through the art of pre-chopping. Next. Everybody knows Dr. Akahoshi, who has been the source of my inspiration. Advantage of pre-chop has already been established that it reduces phenomenally the amount of phaco energy delivered inside the interchamber. I was very much fascinated by Akahoshi's pre-chop forceps, but unfortunately, it had a steep learning curve, interchamber instability, and there were different types of pre-choppers for different grades of cataract, for which I was not comfortable anytime. So I am presenting a sleek design pre-chopper which doesn't have a cross-section like a pre-chopping forceps of Akahoshi type. I am using predominantly a Chang's horizontal chopper through my side port, and this pre-chopper has a very sharp cutting edge to cut the nucleus of any density. This is the diagrammatic representation how the steps of pre-chopping proceeds from 4 to 6, wherein I am converting the entire endonuclear mass into 2 halves of heminuclei, which are subsequently pre-chopped into 4 pie-shaped quadrants. And if you have the patience, you can end up having 8 pie-shaped quadrants. This is drawing of one of my residents. So what is the prerequisite for pre-chopping? An optimal size capsular axis, because it should not be too large, neither should it be very small, because there will be the forces which will be acting from a pre-chopper as well as from the side port stabilizing device like a horizontal Chang chopper. Adequate amount of hydrodissection to ensure the motility of the endonucleus. And you should clear the debris from the anterior surface of the cataract, especially the cortex and some chunk of epinucleus. And last but not the least, a copious amount of viscoelastic to protect your endothelium. So let's get started for the video-based presentation, very short one. So welcome to the world of soft cataracts. Welcome to the intimidating world of soft cataract, I must say. Intimidating, yes, because due to the lack of sufficient hold to perform successful phaco chop. This is a real ordeal for a phacosurgeon. So I am trying to simplify this with the help of this novel pre-chopper. This is a nucleus of sufficient density, but if you are dealing with a very soft cataract, you can simply divide into two nuclear halves and you can emulsify at the intercapsular plane. Here in this case, I am converting into dividing the heminucleus into two quadrants. And the four quadrants are ready now for emulsification subsequently. Let's move to a white soft cataract. Adequate rhexis has been performed. The Chang choppers is stabilizing the equator of the nucleus. The pre-chopper goes through 2.8 millimeter incision, just anterior to the anterior capsular rhexis margin. You go into the depth of the endonucleus, and with these two instruments approaching each other, you divide the entire endonucleus into two heminuclei. With a rotation, you again stabilize the equator and divide that heminuclei into further two quadrants. The next case is that of a dense cataract, and one need to remember that to obtain pristine cornea day one post-op, it is important to make 4 pie-shaped fragment of this dense nuclei so that they can be emulsified at the intercapsular plane under a copious viscoelastic. These quadrants can also be sub-chopped to reduce the effective size of the quadrant. Dealing with a leathery cataract is just like a just like a white cataract is an unpleasant surprise for any phacosurgeon. It is just like encountering a wolf in the disguise of a sheep. So let us not panic. We apply a good amount of patience, a good amount of viscoelastic, a little bit of courage to perform the pre-chop in this stubborn leathery cataract. Here I am using a Akahushi's ball sustainer to stabilize the equator of the nucleus. Sometimes if you find the posterior nuclear plate is not completely separated, then you have to tease that particular plate with the help of dialer-like instrument so that you find the plane of cleavage. PXF and zonular weakness is never a problem if you have already mastered the art of horizontal chop and you apply the same principle. Here I am performing a stretch pupilloplasty, although a little late after having performed a capsular excess. At this level, I would like to pay my special tribute to Dr. David F. Chang, from whom I learned the art of horizontal chopping, though I never had the opportunity to meet him in person. Once you divide the nucleus of medium density into two halves, then dealing with the rest of these two half of the endonuclei may not be a real problem. This is a very, very hard cataract, like a granite. Conquering a granite cataract requires a lion's heart. In this cataract disassembly also, I am using a ball sustainer to support the equator of the nucleus. Copious viscoelastic and patience is the key for the successful management of the granite-like cataract. But you need to understand and appreciate that the margins which are produced after the division with the pre-chopping are almost steep. They imitate something like a flax. Argentina, Argentina, that is what the surgeon is shouting. A catastrophe of a real type has struck. The capsular excess has been lost, and you are left with an Argentinian flag sign, in spite of applying all the possible precautions. So let's have a little patience and let us try to overcome it with the art of pre-chopping, wherein the capsular flaps are designed, and what we have is a pseudo-rexis kind of conversion. And because these two instruments are working against each other, they are acting in a centripetal direction rather than centrifugal. So possibility of tear extension is minimized. Once you fragment these endonuclei, you are ready for emulsification at the anterior capsular plane under copious viscoelastic. Suspected polar cataract. This is obviously a element of caution for the operating surgeon, where he has to exercise control in not doing a nuclear rotation and preventing the interchamber shallowing during any of the maneuvering. So let's pre-chop the endonucleus and get the thing simplified and emulsify each half of the endonuclei of the heminuclei one by one without any rotation. Fortunate for the surgeon that there was no dehiscence. That's it.
Thank you, Dr. Sohail. That was a wonderful demonstration of pre-chop. As you said, in some cataracts, it does require a lion's heart to get in those sharp instruments. What is the tip size of those two instruments, Dr. Sohail?
Tip size of this is a horizontal Chang chopper which is readily available. The other one I am using is a pre-chopper. It is of different sizes. For soft cataract, I am using almost 1.4, 1.5 millimeter, but for a hard cataract, I am using it almost 1.7.
Okay.
So I'm very happy
Dr.
to see
Arup?
Dr. Sohail. You know, I mean, I have been watching you develop this device and this technique, and it has become pretty popular over the years. And congratulations for you for that. And I think, Sai, what we'll do is, since David is already here, shall we take his talk and then we will, you know,
absolutely.
Yeah.
Thank you very much, sir. Thank you very much. Thank you. Thank you, sir.
David, you're here?
Yes.
Dr. Arup, you can introduce.
Yeah,
You can
we'll do
introduce
that.
Dr. Yeah.
Well, welcome, David, to India. Trying to say anything about David F. Chang is like trying to illumine the sun with a torch. You know, David has participated in many conferences in India, both in the personal conferences as well as webinars. He is a clinical professor, University of California, San Francisco, past president and executive committee member of the ASCRS, co-chair of ASCRS Foundation, past chair of AAO Annual Meeting Program Committee, past chair of AAO Cataract Preferred Practice Pattern Panel. He has just given the Ridley Medal lecture last year at the ESCRS, and he has received the 2019 AAO Humanitarian Service Award. David has done a lot of landmark papers in collaboration with Arvind Hospital. Madhu is here, and he is an authority of almost any subject under the sun in cataract surgery. So with these words of introduction, over to you, David, for your talk.
Great. Well, thank you very much. It says that yes, I'm going to share my screen now. It's great to be with you all, and I think this is a nice topic since India, and Aravind specifically, has contributed so much to what we know about this. I have no relevant disclosure. We know that this is a controversial subject because there are some potential disadvantages to intraocular prophylaxis. But it's been 15 years since this landmark study at ESCRS showing a 5-fold reduction with intracameral cefuroxime. I recently was invited to write this editorial to commemorate that anniversary, and this is the only randomized trial. There have been lots of studies since then. Here is a review paper that we did. These are studies that specifically are retrospective, but showed cefuroxime was efficacious, including one large study in the United States. And this led to approval in the EU of Aprocam that did not lead to FDA US approval. And ESCRS has endorsed this. So when you have an inexpensive commercial product, this has a very high safety track record, which it should, because this is a rare complication. I previously conducted surveys for ASCRS in 2007 and 14, and with another 7 years past, I just completed this survey and can give you the results for more than 1,200 respondents, most of whom are American, about half of whom are high volume surgeons. And you can see that over this period, we now are up to 2/3 of people using intracameral antibiotic. Now, if you go back to 2007, half of the time this was put in the irrigating bottle, but you can see that currently it's almost all through direct injection, which makes sense. You know exactly how much you're getting. What's happened with topical? Well, you can see that during this time, there's actually a slight decrease in the use of topical antibiotic prophylaxis pre and post-operatively. And then if you ask, what do you do at the end of surgery? And of course, you may be doing more than one of these things so that it won't add up to 100%. The number of people putting topical has gone down. The number of people injecting in the AC has gone up. Some of the other methods, including intravitreal injection through the zonules, which is sometimes done in the US, that's still a very small percentage. In terms of what antibiotic is used, 3 out of 4 are using moxifloxacin when they do this. You can see that vancomycin has gone way down. So that's a big change from the last survey, when you can see that vancomycin was the leader. And if you just look at the United States, more than half of people doing this were using vancomycin back in 2014. So a big change. And what's changed this, of course, is hemorrhagic occlusive retinal vasculitis. This is our paper done by our task force. We collaborated with the Retina Society. I co-chaired this. And we did an online registry, e-surveillance, a literature search, and in conjunction with the retina doctors, we're able to identify 36 eyes from 23 patients that clearly had HORV. 13 of these were bilateral, and every single one of them got vancomycin in some form or another as routine prophylaxis. There are actually 9 additional cases that we think had HORV, but the data wasn't sufficient. Often we didn't have good photographs to be absolutely sure. So this is following uncomplicated cataract surgery with a sudden loss of vision that may be mild, moderate, or severe without inflammation. I mentioned the vancomycin, and if the second eye was done, and often the second eye was done before the HORV appeared in the first eye, you got a similar reaction with a faster onset and more severe course, as with a hypersensitivity. And some of the eyes got additional vancomycin because the vitreoretinal surgeon was worried about endophthalmitis, and they did very poorly. So here, the second eye will be worse. You can see that the right eye was done first. The second eye is more severe. And this is the worst thing that can happen after cataract surgery, is bilateral blindness due to vancomycin. The eyes did poorly, 61%, 2200 or worse, 22% NLP, more than half got neovascular glaucoma. And of those eyes that I mentioned got the second dose of vanco, they did extremely poorly. So this fits as an immune reaction to vancomycin. A type 3 hypersensitivity, has a delayed onset. And although I guess you could have a reaction to any drug, vancomycin is known to cause a type 3 hypersensitivity in a skin condition, this leukaplastic vasculitis, and it just fits with that. Unfortunately, there isn't a real specific skin test to be absolutely sure that you could conduct on these patients that had it. But based on this, the Academy has strongly discouraged use of this. And then the FDA, in reporting this bilateral case from transzonular injection for so-called dropless surgery, really said that this should not be used. And so from a medical legal standpoint, I think that's why everyone has stopped using it, even though it's clearly rare. If you evaluate the literature, as we said, there's really only one randomized controlled trial. So the Cochrane group said that you really can't rely purely on level 1 evidence, and you have to use the best available evidence. And this editorial from Javid nicely highlights what the predicament is. Because it's rare, you need a huge randomized trial, which would be extremely expensive in the United States, and that will increase the cost of the commercial product that results. And don't we have enough evidence already? Well, in that same issue of ophthalmology was our first paper from Madurai, which looked only at the manual small incision patients for about a year, half with and half without MOXIE. There was a fourfold reduction in endophthalmitis. It was very convincing. And it was actually lower than in their private patients. So Oralab makes Oramox, which is commercially available in India for about US $1. They use this on more than one patient. So this really reduces the cost. You can see the numbers here going from 30 cases to 6. And this is all within 1 year, 14 months, using the same protocols, this being the only thing that changed. So we made the argument that, you know, in situations where we don't have Western standards for OR protocols, certainly in outreach clinics, it certainly makes sense for such an inexpensive measure to prevent infection. With this data, they then started doing this at all of their hospitals. We reported this at 29 months in ophthalmology. And then we continued this until we had 2 million consecutive eyes, half with and half without MOXIE. This won the best JCRS paper of 2019. So if you look at each of these bars is a 3-month period of time. Purple is without MOXIE. Orange is with MOXIE. Remember, there was a transition period to get their 10 different hospitals to transition. So those are the yellow. And the numbers here are staggering, you know, 60,000 in 3 months, 70,000, 80,000. And so you could take any of these periods and compare it to any without MOXIE, and it's statistically significant. The numbers show that we go from 7 per 10,000 down to 2 per 10,000 with intracameral MOXIE. If you look at this 7 to 2 per 10,000, it's interesting to compare it to the US, where we're 4 per 10,000 by our IRIS registry. And of course, as we said, when this data was done, maybe half of surgeons in the US were using an intracameral antibiotic. The same holds for manual small incision. There's an even greater reduction when you're doing phaco. And if we look at posterior capsule rupture as a high risk group, now we have 28,000 cases for a 1.5% PCR rate, which is very excellent considering it's a teaching hospital and this is all comers. You can see that when you have a rupture in the capsule, the rate jumps up 7-fold from 6 to 43 per 10,000. Very, very high. Now, what happens if you use moxifloxacin? Again, a 1.3% PCR rate. Well, you still have an increase in the rate. You go from very low to much higher. But when you compare with and without MOXIE, the group with the MOXIE fared much better. So we made one conclusion in this study was to say, if you're not routinely using it, but you rupture the capsule, you've lost the barrier from the front of the eye to the vitreous, you should use an intracameral antibiotic prophylaxis. Now, what about just routine cases where you don't have PCR? Is it necessary? Well, here's some good data that shows that even in the routine cases, it statistically lowered endophthalmitis, and it was particularly true for phaco. If you only look at phaco, the rate went from 6 per 10,000 down to 1 per 10,000. This is without complications using moxifloxacin. So this data is very valuable. It's really the largest trial for moxifloxacin. This trial was by a questionnaire, so it really wasn't the same type of study. And then when you add the latest data, it's not only the best moxifloxacin study, but I think it's the best intracameral antibiotic study because of the sheer size of data. and the uniform protocols that are used throughout the Aravind system, as you all know. This is a meta-analysis that was done in 2018. It included some of the Aravind data showing that both Moxi and Vanco were probably a little better than Ceph, probably the broad spectrum for gram negatives at reducing endophthalmitis. And all of these papers appeared to show low toxicity, which is, of course, very important with a low risk situation. There's also this interesting study from Brazil, a randomized controlled trial that showed a statistical lowering of endophthalmitis with intracameral Moxi. Now, how did they get this from just 3,600 eyes? Well, these were resident cases, and the PCR rate was very high, about 8%. So if you basically took a high-risk group, resident cases, then you don't need such a large study to show statistical significance, although it barely reached that. And this is now in the literature. So how do we do this? In the United States, we started using Vigamox, and you have to use Vigamox, not any other generic, because this is unpreserved. And there's some studies and reports that this was safe, and so it's fairly widespread now. If you take it directly from the bottle, it is the same concentration as Oromox. Steve Arshinoff has published on this and made the case for diluting it. Because of the fact that when you inject 0.2 ml, 0.1 ml, how do you know if it's all in there? So by diluting it, he can inject more, and he feels he can achieve more reliable concentration. Now, in the US, the other way we access this is through compounding pharmacies, and this is still available globally as well. There's two concentrations, 0.5 or 0.1, and the 0.5 is what's in Vigamox. It's also what's in Oromox. Does it make a difference? Well, we did this study at Aravind and published it in 2019. This is a bilateralized study where one eye got the higher and one eye got the lower concentration of moxifloxacin, and we didn't see any difference in endothelial cell loss that was statistically there. So they both appear to be safe. And on that basis, we feel that the higher concentration, if it's just as safe, probably does a better job. So this is the summary slide. You're trying to achieve this concentration at the end of surgery, assuming a pseudophakic aqueous volume of 0.5 ml. So you could put in 0.1 ml of Oromox, or of the higher concentration compounded, or of undiluted Vigamox, and that will give you that. This is Steve Arshinoff's regimen, where he dilutes it first and injects 3 times as much. Or if you compounded a low concentration, you'd have to exchange the entire aqueous volume to get that concentration. In the survey, it turns out that of those using intracameral Moxi, it's about half and half between those using Vigamox and those using a compounded source. Same also about half and half in terms of the number of people using the higher and the lower concentration. Of course, many people aren't sure what they were using. So why aren't people in the ASERA survey, why are they not using it? Well, some feel they're still not convinced that the benefits outweigh the risk, although look, this has come way down from 90% in 2007, but it's still 2/3 are saying it's the risk of having to compound it or not having a commercial product, which we don't have in the US. Fortunately, in the US, in India, you do. Now, this is a study from Kaiser, and along with this meta-analysis, really showed that it appeared that adding topical, if you're already using intracameral antibiotic, didn't really further improve the rate. And in our survey, if you're using an intracameral antibiotic, 3 out of 4 are using topical, but 1 out of 4 are not. And if they had an approved commercial antibiotic, almost half would either not use it or would consider not using the topical based on this data. As would be expected, the majority of people feel that this is important. 93% of the members surveyed would use it if it was commercially available at a low cost. And again, this is what in India you have available to you. We are, based on the need, working ASCRS with a number of US agencies. Oralab is helping us with the formulation to try to do a very large randomized trial to get this approved in the United States so that we can offer our patients access to what you have in India. And with that, thank you very much, and I'll be happy to take any questions.
Thanks a lot, David. I mean, as usual, it was a very brilliant and informative presentation. So I would just like to know, what is your regimen? Do you use preoperative topic and postoperative topical antibiotics?
Well, based on that Kaiser data, I no longer use topical pre or post-op, and we use povidone iodine. There are some studies that show that doing the povidone iodine as soon as the patient gets maybe to the facilities is better than just putting it on right before surgery. So we do put it in there when they arrive, and then we do the dilating drops after that. And then we do it right before surgery. And I think if your goal is to try to sterilize as much as possible the ocular surface, which I think makes perfect sense, you might as well do it when they arrive and you're getting a longer kill time. And I think largely on that basis, I found that putting in antibiotic, even in the pre-op area, probably makes no sense. And it certainly has simplified things. You know, we are always trying to simplify the post-op regimen. And so I use less drops, and I use a steroid BID, and I use a once-a-day NSAID. And then if they're really, I think, going to need more steroid, I'll inject a little subtenon's Kenalog inferiorly, and that seems to boost things, and that helps me get away with fewer drops.
Have you? What are your views on the dropless surgery?
Yeah, well, I think we all would love to simplify things for patients. We are elderly population, they're forgetful, they get confused, they have trouble hitting the target with their fingers. But dropless totally, I think that's difficult, without, I think, increasing the risk of inflammation and CME. So there's no good NSAID to be injected. So the ESCRS trial on NSAID was excellent, and it really showed that an NSAID plus the steroid together are better than either alone. So I still use a once-a-day NSAID, and I still use, the other benefit of topical steroids, you can inject it and reduce the cell and flare, which in an uncomplicated case may go away pretty quickly anyway. But that topical steroid also really makes the ocular surface feel comfortable. And as you know, these patients, are often complaining more about the discomfort of their eye surface than anything else. And I think having BID steroid for 4 to 6 weeks helps them with that comfort.
Okay. Sai, anything you wanted to ask?
No, I was surprised at the US data that nearly 50% even now are reluctant to. I was under the impression that it was a very widely used in the US.
You talk about intracameral antibiotics, or
yeah.
Well, it's up to 2/3 now, but I think the problem is that if you don't do a high volume and you don't have endophthalmitis, you assume, well, I don't need it then. And, it's more of a theoretical risk. I think the more volume you do, the more you'll have endophthalmitis. And it just takes one case and you realize you're not invincible. And it's such an unpleasant experience that that I think emotionally gets people to cross the barrier. And that's why, again, we have to work so hard. Unfortunately, the history of that ESCRS trial is that unfortunately they did stop the enrollment, and you know, they had their reasons for doing that, but it's largely because of that that we could not get it FDA, you know, cefuroxime FDA approved. So if they have just completed their enrollment and gotten, you know, I think a larger population, we probably would all have intraocular antibiotics approved globally throughout the world. So it was an important study. It did a lot, but it fell short of what we really need. And now here we are 15 years later, trying now to devise a study that will, you know, get through the FDA. That's important because not only does the FDA give access to Americans, but so many other countries go by what the FDA does. And again, we envy you in India being able to have a commercial, I believe more than one commercial sources of intraocular moxifloxacin.
And for the skeptics in who are not using, does it make sense to use it just for the case with the PC rend or a vitreous loss vitrectomy?
Yeah, I think you should. The Irvin data is so compelling. You have a 7-fold increased risk. So now it's not a rare thing, you know, and that's a patient that already, you know, is unhappy and has a, you know, a different prognosis. So I would definitely use it there. One of the questions is, should you use more? You notice that even with intracameral moxifloxacin, still a lot of those cases got endophthalmitis, and of course, concentration is much lower.
Can everyone mute, please?
Yeah. Of course, the when you've got done a vitrectomy, the concentration of the amount of drug you put in is much lower. So that makes sense. So I would definitely do it there. And I think many many organizations doing global outreach and, you know, charitable surgeries with, you know, outside of hospital settings, I think largely on that study should and have been adopting intracameral moxifloxacin.
Gopal, you had a question?
Yeah, I just wanted to say that, you know, moxifloxacin right now has a lot of resistance in the conjunctival flora, which has been described more and more. And gatifloxacin having been, you know, not being used systemically, would gatifloxacin be a better alternative to moxifloxacin? Because moxifloxacin also given systemically for a lot of conditions, and wouldn't, you know, our, you know, use cause more resistance to the systemic moxifloxacin? So what about Gati?
Yeah, so very excellent question, and we didn't touch on, and that is drug resistance. So first of all, this wasn't your question, but intraocular antibiotics are not going to cause drug resistance because that's not the mechanism. The mechanism is through oral, and you expose bacteria to a sublethal dose. They mutate, kind of like COVID is mutated, and they become resistant. So when we inject such a tiny amount in a sterile chamber, which is the anterior chamber, you're basically killing bacteria. You're not going to have emerging resistance. So that's important. But what about all these coagulase negative staph that are resistant to fluoroquinolones? And in the Irvin data, it was actually 43% of their coagulase staph, negative staph, were resistant to fluoroquinolones and moxifloxacin. So why does it work? Well, the way you determine resistance has the way to do with it. You take an isolate that's caused endophthalmitis, you find the MIC that kills it, and then you look what's 4 times the MIC, and you look at a chart and says, what is the systemic blood serum level you can get with any of these drugs? It's based on serum data. but we are injecting so much into the eye that you're getting huge concentrations. And so that is why resistant bacteria that are, quote, resistant to systemic doses and systemic blood levels are not resistant to the intracameral injection. So that, again, is what the IRBN data was really useful for, because in other words, drug-resistant coagulase negative staph are not just in the United States, they are also in India, and yet their data with MOXIE, it is it must be killing that as well. It's a good question, though, about gadafloxacin. I don't think we need to change, but of course, the minute you change the drug, now you have to look at, what are the toxicities and so forth, because again, we're using something, we have to have low risk to what we're using to treat a very rare complication.
Can I ask a question, Dr. Sai?
Yeah, please.
Dr. Chang, at the end of your hi, Dr. Chang. So at the end of your surgery, do you put povidone iodine before removing the speculum?
Yeah. Hi, Mino. Yes, I do. So we do the half 5%, the diluted one. We do it when the patient arrives. So you put in some anesthetic and you put the povidone iodine the very first thing. And then we do all the dilating drops and everything else. And then we do it during the prep. And then finally, at the end of the case, instead of putting, a topical antibiotic on, we use a more dilute version, 1%, because it stings. And we put that on the eye at the very end. So they get a couple, multiple drops at the end. So any time that I would be tempted to use topical antibiotics in the pre-op area, the operating room, or post-op, I just use povidone iodine. It's much better, and it's it's just something you can't give the patient to take home with them. So yes, use any time you have the advantage of an anesthetized ocular surface to put povidone iodine on.
So that is 1%, not the 5% solution.
Well, we dilute it a little further. I think the other way you could do the 5% at the end, you could put a topical antibiotic, topical anesthetic in, but I always did the 1%. I guess there's a theoretical risk that some of it could seep into the anterior chamber. So that kind of got me doing 1%. And I don't have data on this that shows it's better, but I can certainly say I've been doing this for 20 years and have not seen any, toxicity from this practice. That's the one thing I can say.
Thank you, David, for your talk and for addressing the questions. And I know you have a busy day today, and have a good day.
On behalf of the Kerala Society of Ophthalmic Surgeons and the Cochin Ophthalmic Club, a big thanks to you, sir. And thanks to your keynote, the current YouTube viewership is past 1,500. Currently watching this program, almost like a very big hall in a convention. Thank you so much, sir.
Thank you all for inviting me, and I hope you all will continue to be safe.
Thank you. Sony, can you move on and introduce Dr. Sudhakar, please?
While we move on to the next talk on a novel way of dealing with the posterior polar cataract, we have Dr. Sudhakar Potti. He's the Chief Medical Officer at Shankara Eye Hospital, Guntur. He did his MBBS and MS from JIPMER Pondicherry, and his FMRF from Shankara Nethralaya, and fellowship in cornea and anterior segment from L.V. Prasad Eye Institute. And he has over 20 publications to his credit. Over to Dr. Sudhakar for your novel technique of dealing with the posterior polar cataract.
Thank you, sir. Is my screen visible, sir?
You are visible. Yeah, you are
Yes,
visible.
visible and audible. Please go.
Can make it full size. Yeah. You can go to slideshow. Yeah.
Yeah. Thank you. At the outset, I'd like to thank the Cochin Ophthalmic Club and Dr. Arup for having me here. My topic is a small surgical step, is the double tunnel to get out of double trouble.
Kunjo.
Pardon, sir? Am I?
Yeah.
Double tunnel to get out of.
To carry on. Yeah.
Yeah. Double trouble. The mention of PPC itself sends a shiver down most ophthalmic surgeons, and the reasons are obvious. The reported incidence of PC rents prior to up to the 1990s was approximately 26 to 36% in various reports. So that would be a 1/3 chance of hitting a rent and all other complications accompanied by either vitreous loss or nucleus drop or any other such event. But with improved understanding, closed chamber techniques, the incidence of PCR now is being reported at about 6 to 7%. And in fact, today, ECCE, which was earlier, we would say that phaco has a contraindication to PPC. Today, I would say that ECCE would be a contraindication because the chances of complications are more. So there are two types of posterior polar that is commonly. The stationary, which is identified the classical central plaque with onion rings or a bullseye, and it's fairly compatible with good vision provided that the central plaque is small, less than 4 millimeters. The progressive, which is additionally radiating rider opacities, have more symptoms, and these patients present early, typically less than 40 years of age for your cataract surgery. Another grading by Lee et al. Would include the stationary as grade 2, the progressive as grade 3, and grade 4 would be the PPC, which is associated with some amount of nucleus sclerosis. So grade 2, my technique of surgery is pertaining to the grade 4, which is some significant nucleus sclerosis associated with the posterior polar cataract. The risk factors for PCR, 97% of PPC, there is no evidence of dehiscence at presentation. So whatever happens is majority -3% in your hands. And to have a careful surgical strategy would be the way to prevent a large amount of number of rents. I would say that the goal should be to prevent a drop rather than not having a rent, because especially when if you say that your goal is not having a rent, that is going to be virtually impossible. So the idea is to anticipate and take certain care to prevent a drop of a nucleus or any fragment of the cortex or the epinucleus. Another risk factor for the development of PCR would be of the plaque size more than 4 millimeters and a younger age of less than 40. Here, probably the scleral rigidity, low scleral rigidity tends to collapse and causing a vitreous upthrust, which can then already dehisce already a weak posterior capsule. And what are the strategies we have to prevent the posterior capsular rupture? Would be avoid rapid buildup. This is in principle the hydraulic pressure within the capsular bag. Avoiding hydrodissection is that's why we do this. Creating a mechanical cushion above the weak capsule. That's why we do separate the epinucleus so that acts as a cushion. So we could do this delineation straight from the port or from inside out, which is after a trench, as Dr. Basavada has said. Or we could also use a white visco dissection as and the principles of a closed chamber with low flow rates also adds to the safety of the cataract surgery. And pertaining to my topic, when there is significant amount of nucleus sclerosis, the idea is to totally avoid the rotation of nucleus, and that is why we need to slightly modify our technique, because in conventional phacoemulsification, we tend to rotate the nucleus or the heminucleus or any bits of the nucleus, and this we should totally avoid in this case. So this is the first video, which is a grade 4 PPC with a small nucleus. Needless to say that good visco endothelial protection with chondroitin sulfate is a must, and if required, a chilled BSS or a BSS plus would add to the safety.
Your video is not sent, Sudhakar.
Yeah, it is coming. The next is. So this is an NS2. I have started after the Rexis. Okay. So we do a controlled hydrodelineation, sorry, it's wrongly labeled. So we dig into the substance and inject small little bursts and progressively try and increase the number of halos so that the nucleus is totally free. We cannot rotate it and therefore the nucleus has to be totally free. After the removal of the epinucleus, since the size of the nucleus is fairly small, it can just be gently flipped over into the anterior chamber. As I said, we need to have good endothelial protection to prevent severe endothelial loss or post-op striate keratopathy. Once the nucleus is out, it is almost like an open sky with respect to the posterior plaque. So we can safely either do a hydrodissection or a hydrodelineation, because the epinucleus is a single sheet and it is unlikely to drop. And because the thing is open, because of the rhexis and the nucleus is out, there is very little chance of pressure developing beneath the capsule. So it comes out through the entire sheet, moves up towards the corneal endothelium or into the anterior chamber. And of course, we would keep the plaque till the very last before, and that the plaque would be the last thing that we remove. So when the cataract is even more harder, like a grade 4 PPC with even more denser nucleus up to NS3 or NS4, then this flipping of the nucleus into the anterior chamber would cause very significant endothelial loss. Therefore, we would go with, there are different techniques that have been suggested by different authors. Lee and Lee have suggested lambda kind of sculpting, where two trenches diverging from the section are made, and these are individually separated and then emulsified. A horizontal oblique chopping without rotation is also has been suggested. I've tried this, but this is it's far easier to say than done. So this is when I try to do this technique of a double tunnel trench to divide and conquer. Why divide and conquer? All of us have started phacoemulsification with this very, very basic technique of dividing and conquering, where the nucleus is sectioned into 4 with 2 trenches. And therefore, it's safe in almost every surgeon who does phacoemulsification. Now, the issue is we cannot rotate to do the second trench, and that is why I do a double tunnel, so that you can create 2 tunnels and do 2 trenches. And therefore, you can do all the 4 quarters without actually rotating it. So this is one. You can see it's fairly significantly dark brown cataract. And my second tunnel would be done with my non-dominant or my left hand. So because the phaco probe has to be handled by the other hand. We don't do too many maneuvers with the left hand apart from the single trench. So even for a person who is not used to really using your left hand much, this is not very difficult in terms, because it's only a single linear trench that is done. So after the epinucleus is removed, we do a quite a deep trench, like a routine general divide and conquer technique, but this is now being done with the left hand. And any mild irregularities with the left hand can be, the orientation can be easily done with your dominant hand once the first tunnel is done. The second tunnel is done to, second tunnel and second trench is done to complete and make it across. And here we are dividing the nucleus by just lateral separation. The distal part, the distal segment is first then removed after separation. Notice that there is no rotation of any piece. The piece is just directly nudged out after division into the anterior chamber, and the piece is emulsified at the iris plane. And you can notice how dense it is in terms of the brunescent part. And the idea is to minimize endothelial damage in a dense cataract being done at the iris plane, is to attack the piece at the base rather than at the middle or on the top. So once the initial piece is done, the second piece is then separated from the cross. And by now, most of the, you can make out at the back that the plaque is independently moving of the pieces, which means it's easier and safer to remove the nuclear pieces from the bag into the iris plane. Of course, with visco replenishment is a necessary and a must. So once the surgery is complete, we have seen that we have a clean posterior capsule, and we will proceed with the implantation of the nucleus, the implantation of the IOL. So this is a small, 2 small techniques to help handle posterior polar cataract along with significant nuclear sclerosis. And I hope they give young surgeons, young in their career, a little more confidence in handling such difficult situations. Thank you, sir. Thank you for the opportunity.
Thank you, Dr. Sudhakar.
Yes.
That is a very novel way of making a trench. Is that a 2.8 millimeter tunnels that you made in both sides?
Yes, sir. In this particular case,
yeah.
because of the implantation, but I do a 2.2 also, depending on the choice of the implant.
Yeah. Okay, Arup, any comment?
Yeah, I mean, if I just have to add a comment, maybe Sudhakar was very young those days, but the same technique was presented in one of the TNA meetings by the late Dr. Sundaramurthy. So we had a lot of debate on that, why back 2 incisions. And the kind of cataracts that he showed, Sudhakar, another option, the surgical approach also will work out, where you take a wedge, what I do, it must be there in the YouTubes. You take a wedge of the nucleus, chisel up a wedge of the nucleus from the nasal side, You don't have to rotate the nucleus. You just have to rotate the phaco handpiece, the needle, towards the inferior side and toward the superior side, and you get a decent chunk, and you create a lot of space in the central and in the nasal capsular bag.
Yes.
And subsequently, you see that because of the fluidics, the nucleus is already loosened up and it rotates. It comes down to the to the pupillary area. But it is a very Sudhakar, I know, is a very brilliant ophthalmologist, a corneal surgeon, cataract surgeon. Thank you so much, Sudhakar. Any other questions for him?
Thank you, sir. Most surgeons are comfortable chopping only distally, that is opposite the phacoprobe. So that is the reason why oblique chops in the beginner's career, beginner's hands may be a little shaky. And this will give them an opportunity to divide because there are oblique already given, the trenches are there. That was the idea.
Yeah, I mean, a beginner should not be doing a PPC if you do the risk classification.
I'm saying somewhere between a beginner evolving into an expert like Arup.
Evolving into Arup. Okay. Lisa, can you share Dr. Minu's introduction? It's my real pleasure to introduce a very good friend, Dr. Minu Mathan, who is the consultant at Chaitanya Trivandrum. He has won the Shankara Menon Best Paper Award in KSOS, the Best Paper at TNOA, Ophthalmic Hero of India Award at AOS, and the International Hero of AOS Award in 2019. He has published several papers in peer-reviewed journals and presented in ASCRS, ESCRS, all the international conferences. He received the IARSI Special Gold Medal in 2017 and the South India's Got Talent Award in SROs of Mangalore in 2018 and the Shiva Reddy Award of KSOS in 2013. And over and above all this, we know Minu as an excellent cataract surgeon, a very good speaker, and his videos are always a treat to watch. So Minu is now going to speak to us on a question as to whether SICS in certain select situations is a safer procedure compared to phaco. Over to Minu.
Thank you, Dr. Sai, and thank you, Cochin Ophthalmic Club, for this. You cannot start share screen while the other participant is sharing screen. Okay. So you may have to, okay, thank you. Hope my screen is on.
Yes, you are visible and audible. Please go ahead.
Okay, so today I'll talk, especially this is for postgraduates and juniors, and is manual small incision safer in certain select situations? So, and I have no financial interest in this talk. So, as we all know, I don't contest the fact that almost in all cases, phaco can also be done and manual small incision can also be done according to the training. So there is nothing against phaco or against or for SICS or anything against it. It is just a selection of some situations where SICS can be done maybe more safely than some other way of dealing with it. So in certain select situations are going to be difficult situations. So in a difficult situation, if you have to employ a technique it has to be a regularly practiced technique. So if we have learned SICS and if you are regularly practicing it during your career, then you can utilize it if you have a difficult situation or select situation where you need to employ this. But then if you are not in regular touch with this, trying to use it in a difficult situation may land you up in a more difficult situation than what you have right then. So which works best in your hand? In which cases have you done this better, and how many cases have you done with this, and how was the outcome? That determines which is a safer technique for that particular surgeon in that particular case. So with that in mind, let me go into some of the situations where I found this more useful. So this phacolytic glaucoma. So you don't know what is inside. So once I go in through the paracentesis and remove the cortical fluidy cortical material, I inject viscoelastic, and then you can see me just rubbing over the cornea with a wet swab to make the cornea clearer. And now I realize that there is a lot of capsule fibrosis and a Morgagnin kind of nucleus inside. You can't see the size of the nucleus. So it may be small, it may be large. And again, the capsule which is so calcified, you'll never be sure whether you'll get a complete rhexis or not. And in these kind of situations, so here I am doing a rhexis so that you don't go into this calcified areas when you are moving the tearing edge. And now I realize that the nucleus is very small and it can be just visco-expressed out. And the zonules may be weaker. I don't see any movement of the bag right now in this case, but in many of the situations, the zonules will be very weak. So in all these situations, I find that if we do a small incision, large tunnel, things can be more safe. So here is another way in which in hypermature cataracts, when there is no cortex against which you can rotate out this nucleus, we can flip out these nucleus from the bag, even if they are small or even large, by using two instruments, supporting two instruments and picking them out from the bag. So again, if you have larger nuclei and smaller pupil, do not hesitate to use iris hooks to dilate so that you can have an adequate rhexis. That is very important to get these kind of nuclei out in manual small incision cataract surgery. So that is what I want to bring in. After doing a good rhexis, you can even release all the hooks and then bring out the nucleus into the anterior chamber. So the third situation is a black cataract. So this is exactly black. So here the largest possible section for the size of the nucleus has to be adopted. See, to begin, if you are trained in superior SICS, you could do superior, but then I would suggest temporal, because you are going to create a larger one and that is going to induce more astigmatism in superior incision, especially when they have against cerebral astigmatism. So once that is done, and even an 8 millimeter tunnel would be adequate for this, and what is adequate has to be done. See, trypan blue has to be, nowadays we use it for all cases, but sometimes it will be so shiny that you can even do a capsule rhexis without that, and it is quite large. It should be 6.5 millimeter at least, or even I sometimes go to 7 millimeters, so that the nucleus can be brought out very easily. Many of these capsules are not elastic enough to stretch out, and these lenses typically are anteroposteriorly very thick also. So they have to be brought out easily through a large incision. And here don't hesitate to use viscoat. I have no financial interest in this, but the coat the endothelium is very, very important when you are dealing with this. So even this technique is very, very important. So please do many of these cases and then only attempt in situations where you have to use this. See, this is a sandwich technique. Do not try this if you have not done in many cases this technique and perfected this technique. So otherwise these kind of things can happen. You can withdraw one instrument out and the nucleus is not out. So again, I'm trying to extend the sides of the internal incision. Internal opening can be even 1 or 2 millimeters larger than your outer scleral incision, so that the smooth, see the nucleus, you can't have a larger incision nucleus than this. So in very hard nuclei, so if you are used to this technique, breaking the nucleus inside the tunnel, see, half of the nucleus is in the tunnel and then you lift up. So not before that. See, before that, if you lift up, you are going to shave the endothelium off from the 1/3 of the cornea close to your incision. But when you have brought half of the nucleus into the tunnel, then there is thinner nucleus inside the chamber which stands parallel to the iris and doesn't touch the endothelium. So once that is broken, it can be rotated around, and lot of visco has to be used to get out this second half. Here again, please notice the incision is quite large, but still then the technique has to be proper. See, once you bring out the nucleus, if you bring your vectis out earlier than the nucleus having crossed the incision, half of the nucleus, still the nucleus can get stuck inside. So these are all important things which you have to know before dealing with this kind of cataract, especially in SICS. It has to be a really large incision to bring out this nucleus. So you can notice that almost 1/3 of the nucleus has been broken and taken out, and is reoriented in the anterior chamber and then brought out to the anterior chamber. So here there was phacodonosis, but the pupil was not dilating well and could not see the edges of the equator. But the plan was to have a scleral incision. But see, when you're trying to do a capsulotomy, nothing is happening. Because the whole lens is moving while you're trying to cut the capsule. So we realized that the whole lens is free. No zonules at all, just freely floating in the anterior vitreous space. So it can be just brought out in the anterior chamber. In this case, I would say, for me, there are techniques for retaining this and fixing this and all this. But then if you're going in for a technique of scleral fixed diol, scleral planning nucleus, the lens extraction through a scleral tunnel will be the best deal. So this is a little, sorry for the little poor quality of the video because it's a trainee video. But then I would like to show what happens in this video. So this is a phaco started off, quite a relatively harder cataract, which you will notice later. And the rhexis is being made. If you notice, this is not a very large rhexis or not a very small rhexis, but within 4.5 millimeter rhexis, so relatively on the smaller side. And the surgeon now misses the pupil snap, which you see now. The pupil snap sign, and the decompression does not happen. Just pressing on the center does not decompress. You should see the decompression happening. And that is not happened, and you see the pupil snap sign which was missed. And now the first chop happens. And once the first chop happens, you can see that the nucleus, while trying to be rotated, is just moving to one side, not rotating and moving abnormally to one side. So you're pushing and the nucleus remains there. This should make you realize that there is no support there. So now the trainer takes over, and for visualization, the iris hooks are put in. It's very, very important to put in iris hooks and visualize. So here the rhexis is very small, and we have to extend it, make it at least 6 millimeter, cut on the edge, and the dye which was already used helps you better, and try to manipulate this. So in SICS, we know how to bring out a nucleus from a rhexis into the anterior chamber. Use that technique and your skills to bring it out. Once partially the pole is out, we use viscode. There is no vitreous disturbance now. So vitreous is plugged there, and the anterior vitreous face is filled with this one. So to rotate out more, I extend the incision to 3.5 to 4 millimeters. So with that, it was possible to bring the whole nucleus out into the anterior chamber. So now I release all the hooks now, because I want the chamber to be deeper and the iris at a lower plane. And once that is done, now the question of converting. You can go into a different location and do an essay, because the lens is now safely placed in the anterior chamber. Here, this also can be done. From the edge of your corneal incision, you can make oblique or even vertical back cuts on the sclera, and then that can be converted into a sclerocorneal tunnel. So if you make more than 3.5 on the clear cornea or at the limbus, you even after suturing, it will be a bad kind of incision, and it will induce a lot of astigmatism. So to have a better controlled incision, it is always better to have a scleral component of it and extend it to the size which is required for. Anyway, later on in a post PC rent, we'll better put a suture, and so you can extend it even up to 7 millimeters. So this comes out without much of a problem. So once that is done, you take in your vectors. Here again, sheets glide, if you have to put it in underneath the nucleus, is very useful so that you don't drop. Here the nucleus has not been divided completely, so it is just a half division of one single division. So when one pole is taken out, it brings out the whole nucleus. Again, not to miss the use of viscode over the nucleus also to protect the endothelium very well. And now we close the incision so that we proceed with the vitrectomy. The anterior vitrectomy has to be completed very efficiently, and the cortex can be aspirated after we complete the vitrectomy. And here again, the vitrectomy happens through bimanual vitrectomy through paracentesis, so that there is no leak from the main incision. Now we see that the rhexis is intact, it has been enlarged, so a rigid, or even you can use a foldable if the patient has been, it is foldable IOL has been chosen, but it has to be a multi-piece IOL which goes into the sulcus, and because the rhexis has been enlarged, here we may not be able to capture it within the rhexis margin, but then it can be well centered within the sulcus. And once that is done, the sutures are placed back again, or if it's a foldable, it can be placed through the smaller incision, and the conjunctiva is very neatly cauterized, and the section is covered very well and adequately sutured so that there is no leak. And now you saw intracameral use of moxifloxacin, very important, especially in these kind of cases where, and now I use in all cases, but here it's very important to use it. So to conclude, I would say that SICS, knowing the steps of conversion, scleral tunnel. See, we have been doing sessions on stop share sessions in ASCRS to train people on doing sclerocorneal tunnels, and there it's always overbooked. People are ready, willing to come spend money and come and learn the art of doing scleral tunnel. So once you know the way of creating a good sclerocorneal tunnel, you remain much safer than having a very large incision, open incision during complicated situations, and ending up having a lot of sutures and all those things. So thank you very much, and that's it.
Thank you, Minu. As always, wonderful videos and real learning experience for many of the junior doctors and the postgraduates. Any questions for Dr. Minu? Okay, if there are no more questions for Dr. Minu, can we go on to the last presentation by Dr. Mayank Nanavati? Dr. Arup, can you please introduce him?
Yeah. So good evening, everybody, and it's my pleasure to welcome you, Mayank, a very young, dynamic anterior segment surgeon. So he has an intense interest in research. He has worked on astigmatism, wavefront aberrations, ectatic corneal disorders, endothelial disease, lamellar corneal transplant surgeries, quality of vision in pseudophakics, cataract surgical techniques, everything pertaining to cataract surgery. He has over 100 publications, including randomized controlled trials, Cochrane review, case control studies, cohort studies, and retrospective studies in high-impact peer-review literature, over 300 national and international presentations. He has done his PhD, and this was on aspheric IOLs in cataract surgery, and he has published extensively on this subject. Academically, also, he has been on the forefront. He has been a real leader. He has organized, he has been an organizer, a committee member, a panelist, faculty at several national and international ophthalmology meetings and organizations, including the EACRS, ASCRS, AAO, RC Opthal, UKI ISCRS, and BSRS. He is a member of the Scientific Committee, Certificate of Laser Refractive Surgery Examination Committee, and Cataract Surgery Workforce Committee at the Royal College of Ophthalmologists. He is also on the United Kingdom and Ireland Society of Cataract and Refractive Surgery Council since 2014 and has been program lead for UKI ISCRS since 2018 and the honorary secretary since January 2021. I know him personally. He is a very young, very dynamic, and he's a go-getter, and makes his presentations are always very interesting. Over to you, man.
Thank you so much for your kind invitation and kind introduction, Arup, and Kerala Society for Ophthalmology. I'm actually very humbled and honored to talk here in this conference. I see nice presentations by everyone. I was really impressed by the previous presentation by Dr. Menton about the small incision cataract surgery. And I think at some stage we might have to get you to the United Kingdom, Dr. Menton, to show us how you do the SICS so neatly. I'm not going to waste any further time. I'll go back to my presentation. I'm starting my presentation here. Can you see my screen? Can you all see my screen?
Yes. Please go ahead. Yeah.
Thank you. So these are my non-related financial disclosures, but I will mention some of the products which I use during the surgery. To give you a simple example, this is a commonest example when a trainee is doing a surgery. You can see that the phacoemulsification is going on fine, neat and nice, and suddenly they notice a posterior capsule tear. And as you see the tear, they suddenly panic and they remove all the instruments out of the eye as quickly as possible. That is exactly what you don't do. And I often teach my trainees to relax at that point, keep your instruments as they are, and gently remove your second instrument first before you do anything. Keep the phacoprobe inside the eye, even when the tear is there or even when the vitreous is prolapsing. Lower down the bottle height, lower down the aspiration flow rate. As we have learned from Rob Osher et al. Many years ago, that slow motion phacoemulsification will be the best idea in such a situation. And once you've got the parameters under control, use a dispersive viscoelastic such as Viscoat to plug the posterior capsule tear, same as what Dr. Menthan just described in the previous presentation. And once you have secured the tear with the dispersive viscoelastic, that's when you either phacoemulsify the remainder of the cataract if it's safe without the vitreous prolapse, or remove your phacoprobe and then deal with the segment later on. If there is a vitreous prolapse at this stage, I would normally push the segments in the corner, either in the sulcus or in the angle, deal with the vitreous prolapse with the vitrectomy, and then come back to the fragments after the lens has been implanted in the sulcus. I have developed this technique called as face down vitrectomy, because when we do face up vitrectomy, we often tend to have a longer traction on the peripheral retina. So oftentimes importance is not given to where you face your vitrector, facing upwards or downwards. And I believe it's important that we face the vitrector downwards rather than upwards, like so. If you're facing the vitrector downwards in the plane of the PC tear or near the anterior vitreous phase, then we are creating less of a traction on the peripheral retina, and therefore less of the chances of tears, holes, detachment, cystoid macular edema, and all the posterior segment complications that you may have following a vitrectomy. So face down vitrectomy is what I teach to my juniors. And once you've cleared the vitreous near the PC tear and the anterior vitreous phase, you can then come back in the anterior chamber and remove the remainder of the vitreous humor in the anterior chamber. You can always check that with Canalog if you want to. Now, this is a real life example of a student in Brighton who had a pin injury. And as you can see, there's a small corneal incision laceration, and puncture wound through the iris, and the cataract has developed from the lens trauma. We can see that the posterior capsule is traumatized already. So as previously described by other speakers, do not hydrodissect in these cases. I would aim for a smaller capsular excess just in case if I have to place the lens in the sulcus, and then start phacoemulsifying as I show you here. So I'm just going to skip some parts of the video here. Smaller excess, do not hydrodissect, and then go straight to the sculpting part of the video and start removing the nucleus as much as possible. This case is a young patient, and therefore it's easy to just aspirate. As soon as you approach the part where the PC tear is there, you gently remove your second instrument and then plug the hole with a Viscoat or dispersive viscoelastic. Do not remove your phacoprobe at this stage, because that's when the vitreous starts prolapsing. At this point of time, we don't have any vitreous disturbance. Once you have plugged the tear, you can then go back to your phaco or your irrigation aspiration. As this is a soft lens matter, I decided to continue with IA, bimanual IA procedure here. And as and when you start seeing disturbance of the vitreous through the tear, you can always go back to Viscoat plugging of that and then continue with your procedure. So this is Viscoat plugging. Before I remove my irrigation, always make sure you're plugging your PC tear with dispersive viscoelastic. It could be anything, could be HPMC if you've got HPMC on the table, but use of Healon or cohesive viscoelastic may be an issue, because as soon as you go inside now after putting the cohesive viscoelastic, everything will come out in bolus. So dispersive viscoelastic is better in this regards. So at this point of time, I'm not having any vitreous disturbance until I approach the part where the tear is there. And that time I do see some vitreous coming forward. And you can easily go in and stain it with Canalog as described by previous speakers here. Now we moved to something called as Intrasenol, which is a licensed product. As you all know, the Canalog is not a licensed product to use inside the eye, as it's mainly used for orthopedic surgery. But in the Europe, we have got a product called as Intrasenol, produced by Thea Pharmaceuticals. I don't have any financial interest in the product, but that is a licensed product which is now widely available in the Europe. So before finishing your procedure or cleanup of the cataract, always plug the hole with dispersive viscoelastic and then use a multi-piece lens as advocated by previous speakers, and you can capture the lens with the rexes here nicely and neatly. So I'm just going to fast forward here and show you the end part of the procedure, which is this. Now, suturing the wound is also debatable. I used to suture wounds. This video is about 7-8 years old. But nowadays, I don't suture wounds if I don't see any leakage, because the wounds are quite safe nowadays, and we use 2 plain incisions for main incisions and stab incisions for paracentesis. Now, this is a real-life example where a trainee was doing a surgery and they ended up with a posterior capsule tear. I asked them to plug the PC tear with the dispersive viscoelastic viscoat, and this is when I'm taking over the procedure. So when we take over, again, face down vitrectomy, if there's vitreous in the PC tear zone. If there's no vitreous, you can go and remove the cortex as normal. I tend to use the IA cut settings on the Centurion machine, which is very helpful, because with IA cut, in the first 2 foot positions, you can do irrigation aspiration. And as soon as you see the prolapse of the vitreous, you can put your foot down and start doing the vitrectomy without swapping your hands or changing your instruments. And this is a very nice feature. In good old days, we used to have coaxial vitrectomies, and then we used to change a vitrectomy with irrigation aspiration, and that was a whole of a faff and a nightmare sometimes if the PC tear was larger. So here the case is completed with cortex removal. I'm just aspirating the last part and making sure there's no vitreous left in the anterior chamber. And before removing my irrigation, I'm plugging the tear with dispersive viscoelastic. And then we will place a 3-piece lens in the sulcus. But before that, you may also want to check whether there's any vitreous with the intravitreal triamcinolone or Canalog, whichever you're used to using. So just take you to the lens insertion stage here. This is the lens insertion stage, and you can capture the optic. You can again keep on checking for the vitreous even after the lens has been implanted. And use of Myocol is not mandatory. If you think that your optics are well captured and there's no vitreous strand in the anterior chamber, there's no need for using Myocol. Myocol is just to make sure that the optic is covered fully with the iris to ensure that the lens doesn't prolapse and have an iris capture the next day. So that's the real life situation. Now, this is another case where we expected a ruptured capsule. This is a post-traumatic case similar to the first one, and you can see a corneal scar with a puncture wound in the iris and the lens, and the cataract is white. We know that on the B scan, we saw some disturbance of the posterior capsule inferiorly. This is a superior incision being made, and you can see that the capsule is attached to the scar near the iris. So these kind of cases can be tricky, because even though there is no problem with the anterior capsule at this stage, when you try to do a rexus in such cases, you'll end up splitting the anterior capsule awkwardly. So you anticipate that there's going to be a problem with the anterior capsulotomy or capsule rexus in such case, and you have to employ your unusual techniques to have a continuous curvilinear rexus somehow. So as you can see here, the first attempt is to release the synechia we have got of the scars, and in the process, we ended up tearing the capsule. But then once you get that tear, it's important to make sure that that tear is converted into a rexus in a neat and nice pattern. Now, if you're working in a university hospital, you'll always have access to intravitreal scissors and macular forceps and macular scissors. And please don't be afraid of asking for them. The VR surgeons won't know when you ask for them. They're very useful, and I often use macular scissors and macular forceps in such cases to do fine cutting in the anterior segment and finish the rexus in the nicest possible way. So once you've done the rexus, you know that there is a posterior capsule defect somewhere in that region. I'm using the hooks to see how much of a defect I can see. Also, the use of Canalog initially to see whether there's any vitreous already present in the anterior segment. And then once we clear the fluff in the anterior chamber, we find that there is a very full-blown defect at about 4 o'clock. You can also see the corneal scar there. And here the main aim is to make sure that the lens or the nucleus doesn't prolapse in the posterior chamber. And if it does, you have to make sure that the VR surgeons are prepared for this. And it's best to involve the VR surgeons beforehand, telling them that if I manage to drop the nucleus, then you'll be doing a fragmentectomy the following day. So in this case, we did manage to sink a part of a nucleus at the back. But if you do end up in such a situation, it's best to not chase the piece floating around. Leave it for the VR surgeons to deal with that on a second occasion. Do the best possible surgery you can for the anterior segment, and then you can place the lens in the sulcus, like I showed in the previous videos. And in this one, we are using holders and folders, but you can also use the injectors. A multi-piece lens, as mentioned by the previous speakers, is a mandatory requirement in such cases where there's a rip in the anterior capsule as well. Because a single piece lens will not find any space in the bag, and you can capture the optic as required, and then you can remove the hooks and clear the viscoelastic in the anterior chamber. So this was the end of this case here, and the next day the patient was sent to the VR guys to do a fragmentectomy and remove the nucleus. I'm often asked questions about not placing the lens in such cases, but VR surgeons will love you if you place the lens, and I can guarantee that majority of VR surgeons will agree with that, rather than leaving the patient a phakic, because one of the risk of leaving the patient a phakic will be raised pressure, and if the VR surgeons are not able to do the surgeries within 2 or 3 days, then pressure may be an issue long term, and you might end up having glaucoma-related issues with that patient. So moving on to the next slide. This is just a brief video to show you how to use a 3-piece lens through a B cartridge. B is Bravo on a Monarch system for MA60 lens. As the picture shows, you just insert the lens inside, and then it's very important that the leading haptic is pulled out and straightened up with a dialer on the other side. Otherwise, you may end up with kinks and breaks in the leading haptic. So once that is done, and both the haptics are straight enough, then you can start pushing the lens forward. And as the lens opens up inside the eye, you may have to move your wrist clockwise and anti-clockwise to make sure that the haptics are opening nicely. I normally stop after about 30% of the insertion of the lens to allow the haptics to just freely move in the correct position, and then continue with the injection, because if you try to attempt to inject the whole lens in one go, it will end up in an upside down position in the sulcus or in the bag. This is a quick example of what happens if you are in rush to finish the surgery. I was referred this patient the next day after the trainee finished the surgery and said the pressure is 55. Obviously the pressure was 55 because the vitrectomy wasn't complete and there was a lot of vitreous in the anterior chamber. So I took the patient back to the theater the next day. And as Dr. Cheng and others are proposing, in such cases, a pars plana vitrectomy can be useful. And I decided to do a pars plana vitrectomy here just to break the connection between the posterior segment vitreous and the anterior chamber vitreous, and then come back in the anterior vitreous and anterior chamber and remove the anterior vitreous. So this is the pars plana approach to the vitreous, which is remaining in the front of the eye and the back of the eye. So this is to break the connection between the front of the eye and back of the eye vitreous, because mind you, this vitreous is coming around the lens. The patient is pseudophakic with the lens in the sulcus. You can use the paracentesis as an irrigation port in such case. Once you are happy that you remove the base of the vitreous, you can then swap your hands and come back in the anterior chamber and clear the vitreous in the anterior chamber using intrasenol or Canalog of your choice. And this patient then settled nicely with normal intraocular pressure. Next slide. And this is a very simple, easy example for the trainees. This is a patient who was left aphakic by a junior trainee who was not confident placing a 3-piece lens. And the patient, for some reason, didn't turn up for 4 to 6 weeks and ended up with the fibrosis of the capsular bag. So in such cases, rather than opening the capsular bag again and implanting a single-piece lens, it's easy to implant a 3-piece lens in the sulcus, as shown in this video. just implant in the sulcus. Here, if you try to capture the optic, it might be difficult because the fibrosis is already taking place, and you might end up with more retinal issues if you try to capture the optic. So in such cases, use Myocol because you want the cover of the iris over the optic edge immediately after implanting the lens. Now, these are quick examples of secondary sutured lenses, and these are all post-traumatic cases, as you see in all these 3 videos. The video to your top right has got corneal issues as well. So we are planning a DSEC combined with a sutured lens, and these are post-traumatic aniridia patients as well, the patients at the top. So we are planning a Mocha aniridia sutured lens, and we're just going to show you the main parts of the video. To the top left here, you create your pockets, Hoffman pockets or scleral pockets of your choice, and then you use your sutures of your choice. Nowadays, we use Gore-Tex 8.0 from cardiology department, but we used to use Prolene. We know the Prolene breaks after 10 years. And here to the top left, you can see a Mocha aniridic scleral fixated lens going in, which sits in nicely in the sulcus region. You do have to have a large incisions because this is not a foldable lens, and you do end up with some astigmatism here because of the sutures, and this has to be transferred to the patient. So the video to your top right shows some additions of iris to the cornea and the leukocoria, as we call it, with some corneal decompensation. So here again, we are doing an anterior vitrectomy to confirm that the primary surgeon has performed a nice anterior vitrectomy, and then we are going to put a scleral sutured lens in. The bottom video is essentially a simple scleral sutured lens. In the interest of the time, I'm not going to go through the details of that, but I use railrodding technique to pull the lens out. This is an anterior chamber lens, which I, as a corneal surgeon, don't like, to your left top, because it causes corneal decompensation. We often remove these lenses and either clip the lens to the iris or end up suturing the lens. So this is an iris clip lens going in. Sometimes you have to combine the procedure with your VR colleagues, as shown in the video at the bottom there. Here, the VR guy is going inside the eye to do the vitrectomy and do the lasers following the trauma. And I am doing iris fixated lens with a DSEC. So this is an iris fixated lens here going in. These are posterior clip artisan lenses going in. And I think that's the final slide. So when you end up with a problem with an open posterior capsule, keep a dispersive viscoelastic handy. Even if you don't have dispersive viscoelastic handy, it's best to use HPMC rather than Helon or something very hard. Helon Pro is cohesive viscoelastic, so best not to use it. Don't panic in these situations. Avoid brisk movements. Plan your movements very gently, and think about the parameters inside the eye. Lower down the parameters and X slow inside the anterior chamber. Try to do your best you can at the time, and always warn the patient that you might need further procedures if there are any further complications. So thank you so much again to Arup and Kerala and Cochin Society for invitation. I'm going to stop sharing here.
Superb, Mayank. I think you covered the entire gamut of situations and the scenarios. Anybody would like to add something and or ask questions?
Dr. Mayank, is it a standard procedure to always do a pars plana vitrectomy, or which are the choices? When do you do an anterior? When do you do a pars plana? Can you hear me?
Is Mayank there, or?
I think we've lost touch with him.
Mayank has
just,
yeah.
Sorry.
Yeah.
Okay, sorry, I couldn't hear anything, Arup.
I'll repeat that question.
Yeah, sure.
When do you do just an anterior vitrectomy, and when do you prefer a pars plana approach?
The pars plana approach is when the primary surgeon has already placed a lens in the sulcus. And then it becomes very difficult for me to actually undo the lens and then do an anterior vitrectomy. So at that stage, I keep the lens as it is. I do the pars plana vitrectomy first, and then I remove the anterior chamber vitreous without disturbing the lens. If there's no lens and the patient is aphakic, then I'll go for the anterior segment approach. Yeah.
Madhu, any questions?
No, sir. Very nice presentation.
Thank you.
Gopal, would you like to add anything about the vitrectomy?
No, sir. It's only thing that, when you do a posterior, when you go posterior, if you hydrate the vitreous, more and more vitreous can actually come into the anterior segment, and that needs to be taken care secondarily.
Yeah, but infusion actually we normally keep in the paracentesis. Yeah.
Yes. Okay.
Yeah. And another, regarding your bevel up or bevel down vitrectomy, I would like to do a bevel up because I'd like to see what the cutter is doing, where exactly it is located.
Yeah.
And regardless of whether you face it sideways or up or down, the vitreous comes, it comes to the cutter tip.
No, but more important thing, Arup, is to actually do it on the capsule plane rather than the anterior chamber above the iris.
Yeah. In the capsule plane, you see, I would start off the vitrectomy from a plane behind the PC rent.
Yes, correct.
And you sever the stalk, the bridge connecting the anterior and the posterior vitreous.
Yes.
So that is it.
One small comment regarding the choice of viscoelastic. There's a lot of stress on dispersive, but once you clear the anterior chamber with kinolog or whatever, you clear the entire vitreous out. Just for implantation alone, I would then actually look at a cohesive, because once, say, I form the sulcus with the cohesive and then slide in your implant, and then it's easy to remove, and any residual, in case you have, cause the heal-on causes much less vitritis compared to, and it comes out as a bolus. The chance of anything retaining and causing vitritis later would be more with a dispersive. But I said during the surgery, yes, dispersive, but once the just for the implantation, I would still prefer a cohesive.
Yeah, okay. So when you talk about dispersive, it is not HPMC that we're talking about?
Yes, HPMC or viscode, you can do a partition.
They are different entities altogether, So we are talking about viscode, and viscode, it has been shown by numerous studies that post-op ocular hypertension is minimal, it is transient compared to HPMC. HPMC can create havoc. And I would agree with you that, viscode is used as a visco shield. You sort of plug the posterior capsular defect or the zonular dialysis, and rest of the things, whatever you want to create space anteriorly, that we use a cohesive OVD. Moon Wai is there actually. He is a both anterior and posterior segment surgeon. Your nuggets compared to in connection with this presentation?
Yeah, thank you, Ms. Mai. I think it was a great talk about all the possible things that can go wrong. I think when you have juniors, it's always the case. I think I'm a little bit biased towards a pars plana approach because obviously being VR, I seem to think that would actually, as you say, it truncates and segments the posterior and anterior vitreous. So once you do it there, then you're definitely not pulling vitreous forward. So I normally do a pars plana approach. Interesting that you mentioned that, I love the Centurion anterior vitrectomy as well because, the different cut modes, as you said, the IA cut and the cut IA. Yeah. I tend to like the cut IA to remove vitreous because you're not actually pulling on vitreous yet. And I use the IA cut more when, you have the remnant cortical material, and that's what, you use that for. But, one thing that you mentioned about, understanding all the parameters of your machine is absolutely important. I think that's one of the things that juniors should take away.
Sure. I work in a teaching hospital, and because juniors are used to doing IA and position 1 and 2 and 3, I find that very helpful to teach them. So I say, well, nothing has changed as far as your IA is concerned. Only thing is when you put your foot down, it won't be a phaco, it will be vitrectomy. Yeah. So remember that whenever you see a strand, you put your foot down and you start eating the vitreous. So it will be similar like a phaco for them, but instead of phaco, it will be vitrectomy. So that helps them learn vitrectomy faster. With a cut eye, as soon as they press in put position 1, the vitrectomy starts cutting. Right. And oftentimes, if there's cortex remaining, it becomes difficult for them to do an IA and without cutting or chopping or chewing the capsule as well.
What I would circumvent this problem by using a dual linear machine with a dual linear foot control. So you have the pitch and your movement. So you can really control, whenever you want IA cut and or switch to I cut A. It's just by changing over your foot pedal position, you can change it. It depends upon, I use the Goider machine actually, so this gives the dual linear foot pedal control. Otherwise, the Centurion machine also is effective, but only thing is, This is something which you need to set on the machine yourself, or it is
there are only two options: cut IA and IA cut, and you have to ask your nurse to change.
Yeah, that's right. With the dual linear, you do it yourself. I mean, it happens with the foot control.
It's been there with the Infinity also. Cut IA and IA cut. The older machines also.
It is there in all the machines.
You need to, yes.
Yeah, all the machines have it. Even the basic phaco machines have these features.
But I think the dual linear, what you're talking about, you can control the cut as well as the suction.
Everything. I love it.
Yes. That would be much, surgeon control would be much higher.
Yeah, I don't have any experience with that machine, but I gather the Bosch & Lomb Stellar is also works on that principle.
Yeah.
Can I make a small point? See, regarding when the vitrectomy is done, and after that, when you do phaco or when you aspirate the cortex, the aspiration flow rate, I usually keep it very, very low, because once you block the PCR with your viscoat, we do not want it to be aspirated off. So I go close to the aspirating, whatever you need to aspirate, catch it, hold it, and eat it off or consume it. You don't want something to pull it towards you, and that again retains your chamber and your viscoat in the anterior chamber and prevents further pull of the vitreous out. Thank you.
Dr. Arup, can we wind up?
I think we had a great session.
Yeah.
Would you like to go for a group
Absolutely.
picture?
Yeah.
Picture
Yeah. Can everyone switch on their videos, please? Gopal, can we have a
Lisa,
screenshot?
yeah, I will do that. Lisa, Deepak,
Lisa,
and Raju.
Deepak, Raju from Sun Pharma. Deepak is there?
Sohail, look into the camera, Sohail.
Deepak, will 1 sec. I'll just call up Deepak. Anybody can call him up, Lisa?
He must be having dinner. Don't disturb him.
I'll just
it's midnight here for me.
Give me a sec. Yeah, it is very late. It is late.
What's the time in Malaysia now?
12 o'clock.
Midnight.
Oh, it's
12 o'clock midnight.
Yeah. My car is turning.
Weekend. It's all right.
I got to work tomorrow.
Oh,
Saturday.